now dive down into the topic of respiratory system, and I'm going to describe a MCQ that has been asked in the previous years. The question says that a patient is presented with cough and shortness of breath episodes for the last 2 years, for which he has taken treatment but has no records as usual patients would do. But because in this question there is mention of episodes of shortness of breath, then episodic shortness of breath is usually a feature of obstructive airway disorder. So this could either be asthma or it could be COPD exacerbations occurring in the person. There is no occupational risk factors. He reports growth of molds in his house due to leakage, water leakage, because of which the molds are present. So I am also suspecting that this guy could be having allergic reaction to fungal spores as well. The CT chest reveals basilar emphysematous changes. This is one of the key words of this MCQ, basilar emphysematous changes, and he says which test would help in diagnosis. A says serum precipitants against Aspergillus species, which looks like the answer because the allergic reaction to fungal spores. The hint is present in the fourth line of the question, so I thought it could be allergic bronchopulmonary aspergilloma. Allergic bronchopulmonary aspergilloma is usually common in asthmatics and also patients of cystic fibrosis. The fungus which is responsible for this is Aspergillus fumigatus. But as I'm glancing at the options, I'm noticing that skin prick test for Aspergillus, that is also useful for diagnosis of allergic bronchopulmonary aspergilloma. So my first thought process in this question is that for diagnosis of this particular case, either option number A will be correct or option number C will be correct. Now, what is telling me that this approach of mine is wrong is that in allergic bronchopulmonary aspergilloma, when you read the literature, the HRCT chest of the patient will reveal a very classical finding that you don't read anywhere else. I mean, you read about upper lobe, middle lobe, lower lobe bronchiectasis, but this very classical term is not read anywhere else. That is going to be central bronchiectasis in a person. And even the clinical features of allergic bronchopulmonary aspergilloma, the patient will be having passage of brownish sputum plugs. It's an allergic reaction to the fungus per se. There are two reasons why option A and option C cannot be the answer to this question, because both A and C are useful for diagnosis of APPA, but the CT finding of APPA is central bronchiectasis, whereas in this MCQ it is mentioned as emphysematous changes. Now, if I look at option number B, flow volume curve with a non-reversible airflow obstruction. We know reversible obstruction is asthma and non-reversible is emphysema / chronic bronchitis, that is COPD. But my point is, if I am already aware of the fact, I agree that non-reversible airflow obstruction is emphysema, that's fine. But if CT is already giving me evidence of emphysema, if CT scan is already telling me that the person is having presence of emphysema, then spirometry will not give me some additional inputs. Rather, I would like to utilize this opportunity to find out the etiology behind the development of emphysema in this person, and therefore the answer to this question also cannot be option number B. I repeat once again, why I ruled out option number B is because it is not giving additional information. I already know his emphysematous from the CT scan. I now need to find out what is the etiology behind it. I'm not saying that this is a case of alpha-1 antitrypsin deficiency, because for that you need to demonstrate concomitant cirrhosis also. We also need to do a liver biopsy and demonstrate that okay, there is alpha-1 antitrypsin deposited inside the hepatocytes, which is screened by PAS, that is PAS positive diastase resistant inclusions are seen inside hepatocytes in alpha-1 antitrypsin deficiency. So why the answer to this question is B and not option number B is primarily that option number B is not giving you additional information. I am trying to go for etiology behind the development of this patient, and the test is trying to analyze whether you can think like a flowchart that is given in the book, right? First investigation, next investigation, third investigation. The thought process is, okay, if CT is showing a particular damage, then you need to find out the reason behind the development of the damage, which is why the answer will be option number D for this question. Now, moving ahead, what I'm going to show before you here are called as flow volume curves, and they are grossly different from the spirometry curves that you learn in physiology. In the flow volume curve, I will be asking the patient to breathe in. I will ask him to breathe in as hard as he can. It will take a few of practice breaths on the part of the patient, but I will be expecting this patient to completely try as hard as he can and exhale out, empty his lungs. Once the lungs are empty, it's obviously lungs can't be empty because obviously there's residual volume, but my objective is to make him do some practice breaths so that he tries to empty his lungs as hard as he can, and then I'll tell him breathe in as hard as you can. So I'm trying to upgrade from the residual volume to total lung capacity. This point that I mentioned is TLC of the patient. Now I will tell him, sir, again breathe out as hard as you can. So my objective is that I want to check out the surface area which is covered under this, which can be done statistically with the computer. And in a normal individual, the curve will look like the way that I've shown. But if a person is having, let me say, bronchial asthma is a disorder of expiration. So in an asthmatic, this inspiration part may almost be the same, or it might be superimposed on the original curve. I have deliberately made it a little smaller as compared to the traditional one so that I could just delineate the two colors. But now will come a difference, because asthma is a disease of expiration and there is going to be a resistance to the expiration component. So you are going to have a concavity. As you can see, there's a concavity that I'm showing at the moment. So the first curve that I have shown here before you is a flow volume curve, which simply tells you that there is a obstructive airway disease in a patient. Now, whether it is asthma or whether it is COPD, I can give bronchodilators to the patient. Suppose after giving bronchodilator, if I find that this curve goes towards normal, I said I did the test and after 15 minutes I repeated the test. If I find that this curve tends to go, the one in red that I've drawn before you, if it tends to go towards normal, it means that it is asthma. If it remains the same, then it is COPD, because that's a non-reversible airflow obstruction. But in the second curve that I am currently showing you, what is happening is that there is a universal flattening of the entire curve. Now, why this could be happening could be mainly because of tracheal stenosis in a patient. Like, let me say this person developed Delta variant of COVID-19 and he was hospitalized and he required intubation for maybe more than 2 weeks. Usually we don't do intubation that long. We might have to go in for tracheostomy, but let me say the patient load was so high that tracheostomy could not be done on time, and the person subsequently, though you saved him from COVID-19, but because of prolonged intubation developed a tracheal stenosis. A tracheal stenosis, there is still going to be an obstruction during the inspiration part also and the expiration part also. So this curve has been drawn before you simply to tell you that I taught about an obstructive airway where there was a problem with the parenchyma of the lungs. But this time the problem is not in the parenchyma, the problem lies with the trachea. So this is a curve that shows a fixed obstructive airway disease. You see, the point is, when it comes to asthma, I said I could even make this concavity go away by giving a bronchodilator. But in this case, nothing is going to work. And mainly why I'm calling it fixed is because both the components are going to get flattened and are going to remain the same in this person. Let's compare this with the next curve that comes up. As you can see, there is still a flattening present, but the flattening is present only in the expiratory part. So the term that I will use for this particular description will be a variable obstructive airway disorder. Why I am calling it variable obstructive disorder is mainly because of the fact that the problem is not both in the phase of if it is problem in both inspiration and expiration, I will call it fixed. And if it is going to be a problem only with one phase of respiration, but it is not that concavity, it is a flattening present, then I'm going to call it a variable obstructive airway disease in a patient. The reason why there is a flattening present could be maybe because there is a growth that is hampering mainly the expiratory part of the phase of respiration. Let's compare this with the subsequent curve that I've shown, where this curve has literally become like a small circle. This is usually encountered in patients of generalized myasthenia gravis who tend to develop a diaphragmatic weakness. So it would be wrong to write the word diaphragmatic weakness. I would just like that in patients who are having neuromuscular disease, ultimately even respiratory muscles can get involved. So you will notice that the entire curve, instead of the way I have shown before you, the curve will become relatively small and would look like I can use a different color to draw it. In fact, the curve would be very small and would look like a small circle like I have shown in dotted green here. Now I will be telling you how restrictive airway disorder would look like, and for this a bit of mathematics here. When you look at this flow volume curve, this is the inspiratory part, this is the expiratory part. I told you that you upgrade from the residual volume total lung capacity. But in all patients who are having restrictive lung disease, the highlight of restrictive lung disease would be presence of pulmonary fibrosis. Because of the pulmonary fibrosis component, what is going to happen to TLC? It will be less. It cannot be 6 liter. It cannot be 6 liter. It will be lesser than 6 liter. Primarily why? I mean, why lesser than 6 liter? Because there's a pulmonary fibrosis component. So when I'm going to draw the curve of a restrictive airway disorder, you will notice that in this particular person, the curve will not end at 6 liter, but will be ending earlier. I repeat that again. The lung is shrunken. Because of this shrunken lung, the TLC of the patient will also be lesser, and even the residual volume of the patient, the RV of the patient will also be lesser because of the pulmonary fibrosis component. So let me start this curve. The curve I'll show in red will be starting a little more towards the right because RV is still lesser. Let me say instead of 500, 400 ml, and it is ending at only 4 liters, or let me say ending at 3 liters. You can see that I have shifted the position of the curve in a person of restrictive lung disorder. The black is the representation for normal. The reason I have done this mathematical shifting is mainly to sensitize you to the fact that because lung is smaller, so therefore TLC, let me say, has been shown to be 3 or 4 liter, whatever. And now I'm going to do the expiratory part also, where what I will do is also try to show you that the tip of this looks relatively pointed. Every time I have drawn a flow volume curve before you, you will notice that the upper part was never very pointed. You can see the even in dotted fashion, it was a little rounded but never pointed. This pointed appearance that I'm showing you is casually also written as beanie cap appearance. The messages are that if you want to answer in the MCQ that the patient of yours is having restrictive lung disorder, one of the reasons for restrictive lung disease can be like asbestosis, or restrictive lung disease could be idiopathic pulmonary fibrosis in a patient. I cannot comment on the diagnosis as IPF because that's a histopathological diagnosis. I need a lung biopsy for that, but I can just say that this is a restrictive lung disorder because of two facts. One, the curve is shifted a bit, as you can see in the original representation given, and also I've tried to hand draw the same thing before you, and over and above this, that beanie cap appearance as well. The two must know facts that you must know from the flow volume curve, at least for FMG exam, you must know is because they've been repeated very frequently, is that this would be restrictive versus obstructive airway disease where the concavity comes up. Though I've tried to go beyond that also by talking about a central airway obstruction versus a central fixed obstruction, tracheal stenosis, I'm calling it central, versus a variable obstructive airway disease versus a neuromuscular disease as well. So there's a separate video in the main section of the app for the flow volume curves, and you can go through that as well. And now I will be attempting a question that came a similar lines. Actually, this question was asked in FMG exam in a simpler format, and now I'm going to discuss this question of NEET PG 2022. And in this question, this curve was given, and let's evaluate the question on the basis of the merit that it deserves. This question from NEET PG 2022 said a 40-year-old smoker has joined a construction company. So when you read smoker, it points towards possibility of COPD. And when he says construction company, then you're thinking maybe he is having exposure to cement and could end up with asbestosis as well. The flow volume curve of the patient is shown, and now when I zoom into the flow volume curve, you can notice characteristic concavity or a semblance of slight concavity present in the red curve, which goes in favor of obstructive airway disorder. Another reason why I'm saying obstructive airway disorder is that he has also mentioned the word pre-bronchodilator and post-bronchodilator. And you can notice that there is a change in the FEV1 of the patient. I'll just read out the values before you. The FEV1 of the patient before was 3.55, now it is 4.64. So there is a slight increase present. In fact, another hint is that whenever they give you a report like this, where pre and post bronchodilator report is given, you can straight away look at FEV1 FVC ratio. In all obstructive airway disorders, this FEV1 FVC ratio, especially with respect to COPD, the ratio will always be less than 0.7, whereas in this question it was given to be 68, which again gives credibility to possibility of COPD in the patient. There is also a slight change in the FEV1 of the patient. There is a change. How much is the FEV1 writing? The mathematical value, because it might be looking a little blurred to use, about 30%, because there's a 30% change. I told you, or in fact I can say at the moment, that when do you say reversibility? You say reversibility when the FEV1 of the patient increases by approximately 12%, whereas in the question it was given to be 30%. So this is a case of a reversible airway disorder. And on the basis of this, now if you look at the options, you can easily rule out restrictive airway disorder. For restrictive airway disorder, there would be a beanie cap appearance, and at the same time a shift of the curve. The curve would be shifting in this particular direction. I mean, in this particular slide towards this particular side. I said in this slide to this particular side, right? And the beanie cup appearance is also not present. We are left between obstructive etiology with response to bronchodilator and no response to bronchodilator. There is a response to bronchodilator, because of which the answer to this question would be given as option number C. Whenever they give you a question like this, always look at the shape of the curve and then compare and have a look at the diagnostic criteria of reversibility. If reversibility is demonstrated, it is asthma. If it is a non-reversible airflow disorder, it would be COPD in a patient. I mean, it's not necessary that the smoker will be having COPD. This could be an asthmatic also. We as doctors are told him don't smoke, but because of his peer pressure, he started smoking, or because of pressure in the office, he thought, okay, let me, one of the cheapest forms of addiction is cigarette smoking. So he tried to basically misguide the thought process of ours. The examiner in this question has tried to throw us off the track by giving us information in the first line which is not consequential. So not every word that they give in the exam is relevant for the answer to that question. After all, evidence-based medicine says that it is investigations that will diagnose a case. It's not the clinical history. I mean, history alone is never diagnostic. You need to look at the evidence also. So what I'm saying is, earlier the thought process was history and clinical examination is sufficient for diagnosis. But here there is a clear-cut demonstration. I mean, smoker, construction company, the combination of the two made us thought in possibility of both disorders. And look what it turned out to be. There was a 30% change in the FEV1 of this patient, and the FEV1 FVC ratio was also showing a substantial improvement, which tells us that this guy is an asthmatic and maybe he had never been diagnosed or was never taking proper treatment for the same. The answer to this question is option number C. So flow volume curve is an important topic from the exam perspective, and we next focus on the topic of pneumonia. They've asked what is the commonest cause for community acquired pneumonia. The answer of yours would be given as pneumococcus, that would also be called as streptococcus pneumoniae, and usually there are no errors in answering it. Pneumococcus is the same organism that we have also discussed is the leading cause of acute bacterial meningitis in both adult as well as pediatric population. Now the question says pneumonia in an AIDS positive patient and there is a low CD4 count. The first thought process of ours is that every time there is going to be low CD4 count, let me say the CD4 count of the patient is given to be less than 200, then one of the opportunistic infections that always must be considered is pneumocystis jirovecii. Now, whether you will answer jirovecii or not is dependent on what is given in point number 1 and 2. And the point number 1 was a NEET PG 2021 MCQ that I want you to listen to very carefully. He described an AIDS positive truck driver. He spoke about pneumonia. He talked about low CD4 count. But then he told that the person is having bronchial breathing and lobar consolidation. In pneumocystis jirovecii, we do not have a lobar consolidation and we do not usually read about bronchial breathing. If the information given in the question is point number 1, then the answer for this would be given as pneumococcus. And even Harrison says that the leading cause of pneumonia in an AIDS positive patient is pneumococcus. Why? Because even AIDS positive people will be living in the community, so they could also be getting a pneumococcal pneumonia. So even if the question tries to misguide you by giving you a CD4 count, low CD4 count is suggestive of, it is not confirmatory of pneumocystis jirovecii pneumonia. How do you confirm the diagnosis of jirovecii pneumonia? It is by doing a bronchoalveolar lavage, where you will have to then stain it with a gumori-methamine stain and you would be able to see those black cysts of pneumocystis jirovecii. Why do you call it pneumocystis? One, it can cause pneumatoceles in the lung. And you call it pneumocystis because the cysts would be, the word cystis also tells you there are cysts present in this fungus which can be stained with gumori-methamine stain, which is a green stain. Now, what is the point in the question that should make you answer that, okay, this can be given as pneumocystis jirovecii, is the following information of X-ray and auscultatory findings also, because bronchial breathing is very, very specific for diagnosis as lobar pneumonia. Though he can also give you X-ray. But my point is, at the moment, even if he is not giving you X-ray, you should be able to identify the fact that bronchial breathing is a feature of lobar pneumonia, which is caused by usually pneumococcus. When it comes to Girovesi, the chest is usually clear. It would usually be an interstitial pneumonia. In the later part, you might be able to hear some rales or some crepitations in the chest, but most of the time in Girovesi, the chest may be clear. Now, when you are going to do the X-ray of the patient, on doing the X-ray of this patient, you will be getting a finding of reticular interstitial changes, which would be bilaterally symmetrical. So let me just show the X-rays to you as well. Let me just zoom into these two X-rays. In one of the X-rays, the highlight that you can see is a feature of lobar consolidation. This would be on the left hand side. So this is a left upper lobe consolidation in a person. Whereas in the second one, I can call it right middle zone consolidation. But in both of these images, there is a patch, and this patch is suggestive of lobar pneumonia, which would be mainly a radiological presentation of pneumococcus. But if you contrast this with the image that is currently on the slide, you will notice some bilaterally symmetrical hilar opacity is present. In fact, this particular star mark I would like to place a little more superiorly. Yes, now it's at the right place. So these reticular opacities that you can see and even are present a little more distally. Let me, I erased it. So I think now it is much more clear that the image on the right hand side, this is more suggestive of pneumocystis jirovecii. Again, I said suggestive. And what are other hints that could help you in diagnosis is HRCT chest, which will show a ground glass opacities. You read about ground glass opacities even with respect to COVID-19 pneumonia also, no? So can't it be that this chap is having COVID-19 pneumonia? Possible, no. So what is the other hints that would be present? Then you will notice that in COVID-19 pneumonia, there is a hypercoagulable state, so D-dimer values will be elevated. But in a patient who's having pneumocystis jirovecii, it is LDH values that are elevated. There is also an increase of alveolar arterial gradient. And to confirm the diagnosis of this patient, anyway, a broncho-alveolar lavage will be done. For COVID, we'll obviously do a RT-PCR. It will turn out to be negative if it is jirovecii. And the ball of this patient would then be stained with a gomorimethamine stain. And then we'll be able to demonstrate the cysts present. The treatment of this patient will now be subsequently started. The drug of choice for treatment as well as prevention is trimethoprim sulfamethoxazole. This is both the DOC and it is also used to prevent the development of this opportunistic infection. Other drugs that can be used are pentamidine, clindamycin, primaquine, atovaquone. Primaquine, atovaquone you read in malaria also. And one more surprising thing is that like in COVID-19 we give steroids, we also give steroids in pneumocystis jirovecii as well. That's an important point to be remembered from the exam perspective, that steroids are useful for interstitial pneumonia caused by COVID-19 and is also used in jirovecii. The logic is that in jirovecii pneumonia, when you kill it by giving cotrimoxazole, the allergic reaction that occurs can cause release of cytokines, and that cytokines can actually worsen the inflammatory picture. Same happens in COVID-19 also, no? That there is a cytokine storm usually occurring after day 10 with the Delta strain. The person may die not because of pneumonia, but because of the cytokine storm that will cause multi-organ dysfunction in the patient. Steroids are useful both in COVID-19 pneumonia. We use it for moderate to severe cases of COVID-19, and at the same time, steroids are also useful in pneumocystis jirovecii. The most important point from this slide is that every time you read a question which is suggestive of low CD4 count in an AIDS positive patient, don't jump the gun and straight away answer jirovecii. Read the information provided. If it is going to be bronchial breathing, lobar consolidation described on X-ray, then it is pneumococcus. If that is not the case, if he says chest is usually clear and says that there is bilateral symmetrical perihilar infiltrates present, then it is suggestive of pneumocystis jirovecii in a patient. And suppose this information is not clear and he simply says which of the two is more common, then on a comparison basis, I'm putting 2 stars versus a single star to say that this is written in Harrison that the commonest cause of pneumonia in an AIDS positive patient is pneumococcus. It is not pneumocystis jirovecii. On this slide, I'll be teaching you regarding organism specific approach for pneumonia. If he says what is the leading cause of pneumonia in an alcoholic patient, the answer is still streptococcus pneumonia, because that would be coming from the community again. But lots of time there is a question that will say alcoholic is having passage of red currant jelly sputum. Now you all know about red currant jelly stool in a 9-month-old baby, that is intussusception, but red currant jelly sputum is always a feature that you read with Klebsiella pneumoniae, where you have a necrotizing pneumonia and that physical damage in the lung causes this red currant jelly sputum. In contrast, when it comes to oral anaerobes in the alcoholic patient, then there is also a possibility that these oral anaerobes can contribute to necrotizing pneumonia and even a development of lung abscess. And one of the highlights of lung abscess would be a presence of an air fluid level. So when you see an X-ray of a patient and it is having a circumscribed shadow, and that shadow will cause the pus to settle at the bottom and the air will be on the top, then I'm going to call it an air fluid level. Normally you read about air fluid level in a patient who's having, multiple air fluid levels can be found in interstitial obstruction on an X-ray abdomen of a person. But I am today teaching you a reason where air fluid levels could be present in the chest X-ray of a patient due to lung abscess. And for the treatment of this lung abscess in a person which is caused by oral anaerobes, the answer will not be given as metronidazole but should be given as clindamycin. The description of the previous year question will be, question described went like this. I'll just say that verbally. A question said a young guy on Holi festival drank a lot of alcohol and did drugs also. Like he drank bhang also, he took bhang also, and then he maybe smoked some cannabis and he did alcohol also, as people do on Holi festival in India. And then he was sleeping continuously for 2 days. He woke up with high grade fever and was also having halitosis and was having purulent bronchoria. Every time he was coughing, he was spitting out pus. Then you must think what really went wrong in this guy was that when he was sleeping under the intoxication of alcohol, he aspirated. There was so much of intoxication that the airway defenses became lesser. You see, alcoholic patient, when he is under influence of alcohol, large amount of alcohol being consumed, then airway defenses will become less. And when airway defense will become less, then there can be microaspiration of saliva, because of which oral anaerobes will contribute to problems. In fact, just another example that I can give on this slide is, suppose I have a patient who's having dementia or a person who's having stroke, and these patients of stroke can go into coma also. Any patient who's having stroke, if there is a bulbar palsy or a pseudobulbar palsy component, even then the cough reflex of the patient would be hampered. Every time there is an impaired airway reflexes, there is a possibility that the person can have microaspiration of his saliva, and one of the common organisms in the saliva is anaerobes. So oral anaerobes will be usually given in scenarios of impaired airway defense. What are the scenarios of impaired airway defense that I've given you? I've given you 3. One is alcohol/drug intoxication. Then is going to be a dementia patient. In late stages of dementia, person becomes bedridden and he can aspirate on his saliva. And most patients, neurological illnesses, even Parkinson's disease patients, in the later stages, they could be having impaired airway defenses. They develop pneumonia. That pneumonia that comes, like in Muhammad Ali's case, he had Parkinsonism, he died because of pneumonia. In later stages, when he was completely bedridden, he would have aspirated on his own saliva. So impaired airway defense. 3 scenarios, the answer is oral anaerobes and the treatment is clindamycin. But if he talks about a person who's having COPD and is having a pneumonia episode, the organism is Haemophilus influenzae. I'm discussing a table given in Harrison where there is an organism-specific approach for pneumonia. For lung abscess, either it could be MRSA or it could be oral anaerobes again. He will divide the discussion into primary and secondary. Secondary means due to some other cause. Like suppose a person is having a tumor. If there's a tumor in the lung, it will hamper the airway clearance. It will hamper the airway defenses. So every time there is a foreign body in the lung, or there is FB means foreign body here, if there's a foreign body in the lung, or there's a tumor present, or there's some infection present, it will hamper the original mucociliary escalator. Normally we have cilia beating in the same direction and they keep the lung clean. If there is any external influence that helps in development of a lung abscess, like there's a foreign body aspirated by a child and then subsequently there is a lung abscess, I'm going to call it secondary, that is going to be MRSA. But if he says primary, the answer is oral anaerobes. However, in the question, if he gives you a history of a hotel stay or luxury cruise, then it is Legionella pneumophila. The speciality of Legionella pneumophila is that it can be even transmitted via water droplets or water being responsible for diarrhea. But here I'm talking inhalation of water droplets can contribute to Legionella pneumophila, where there can be 2 presentations, Pontiac fever, which is milder, and Legionnaire's disease. And another problem with Legionella pneumophila will be, and you will notice that in large number of MCQs will be an endocrine association, that is SIADH, and because of this there will be a euvolemic hyponatremia in the patient, and this hyponatremia can be severe enough to cause confusion and seizures. Normally in pneumonia, confusion will occur because of hypoxia, but here I am teaching you Not hypoxia contributing to confusion, but I'm teaching you electrolyte imbalance contributing to confusion and disorientation and seizures in a patient. That electrolyte imbalance is thanks to SIADH that can develop in this condition, and because of the peculiarity that we are having an endocrine problem, electrolyte imbalance in a pneumonia patient. Traditionally, pneumonia is all about lungs, but here I'm talking about electrolyte imbalance with a pneumonia. That's why we call it a atypical pneumonia, for which macrolides would be used. Then SARS-CoV-2 for infected humans. For birds, we can either have psittacosis or it could be Histoplasma capsulatum. For rabbits, especially if he gives you a history of a hunter, and this hunter will then develop a eschar, because Francisella tularensis, that is tularemia, would mainly be transmitted via ticks. These ticks would be living on the body of the rabbit, and when the rabbit is being skinned, like this hunter, he shot the rabbit. Now he's skinning the rabbit. So from the skin of the rabbit, the tick will jump over to the hand of this hunter and will bite the hunter on his hand. Subsequently, there could be a bite, that is a eschar, that could be developing in the hand of this guy, and there would also be enlarged axillary lymph nodes. So when it comes to tularemia, another term that we also read is ulceroglandular fever. This is a question that was given in the MCI exam. The question said that a hunter, after killing a rabbit or skinning a rabbit, after a few days developed an eschar on his hand and axillary lymph nodes. What is the presentation? That would be that of tularemia. When it comes to exposure to sheep, there could be development of Coxella burnetii. Coxella burnetii is what you also read as Q fever. And this organism is notorious enough not only to contribute to, a pneumonia in a person, atypical pneumonia, but can even cause endocarditis as well. So especially in infective endocarditis topic, when I'm talking about Duke's criteria, you will hear me talking about one blood culture being required. In all others, no, multiple blood cultures, at least 2 to 3 are required to say, okay, this is the organism response. At least 2 blood cultures of the same organism, like Staph aureus in culture number 1 and culture number 2, to say it is infective endocarditis with respect to blood culture. But only scenario in infective endocarditis where one blood culture report is sufficient is Coxella burnetii, which has been discussed today as a cause of development of pneumonia. So this is an organism specific approach for pneumonia that you should be remembering. Now the question arises that how should we treat a patient of pneumonia? Should he be treated on OPD basis, IPD basis, or ICU basis? So the decision making is done on the basis of Curve 65 score, where alphabet C would stand for confusion in a patient, for which we can use a mental test score of less than 8, or just generally in the ward, if a person is having disorientation to time or to space, like he doesn't know he's in the hospital or he's at home, there's a disorientation to any one of these, either to time or to space or to person, that means that the person is having confusion due to hypoxia. Then would be uremia, in which blood urea nitrogen would be elevated. R would stand for respiratory rate, the value to be remembered is more than 30. B would stand for blood pressure value of the patient, which should be less than 90/60. This less than 90/60 implies that there is sepsis occurring in a patient and probable septic shock also. And if the age of the patient is more than 65 years of age or equal to 65 years, then this Curve 65 score, we give 1 point for each of these parameters, and depending on the final score of the patient, we'll be deciding OPD versus IPD versus ICU care for the person. Now, the decision making process, I want to tell you that in lots of multiple choice questions, he may not mention blood urea nitrogen, but he might actually give you blood urea report of the patient, as happened in NEET PG 2022. So I want you to remember either of the two formulas. Either the formula is 1 is equal to urea divided by 2.114. That means, like, suppose the 1 is given in the question to be 10. Suppose you read the question, 1 is given to be 10. Then how do you calculate urea? You just need to multiply this by 2.14 and you would get urea. Or if he gives you, a 1 value, whatever be the 1 value, you can multiply it by 0.35 and you would still have the urea value of the patient. The difference is that it could be milligram per deciliter or it could be millimoles per liter. Please pay attention that in this particular classification, which is an American classification, the 1 value is more than 7 millimoles per liter. It is 7 millimoles. And what happened in the exam was he gave a blood urea, and the blood urea was described in milligram per deciliter. So you had to do this mathematical calculation. It is one-step calculation only, no? From the urea, whatever is the urea value given, divided by 2.14 and you get 1 in the patient. Like suppose I'm saying just for the sake of calculation. Suppose urea value given is 21.4. You just need to divide it by 2.14, no? So 1 would be coming something around 10. But if I say 1 value of 10, that is more than the cutoff of the threshold values. Now, If the score of the patient turns out to be 0, then the mortality is about 1.5% and the person can be treated at home also. OPD based treatment can be done. However, if the score of the patient turns out to be between 1 to 2, then the mortality rate is higher and I would like to admit this patient on an IPD basis. The question that came in the exam had one age feature, that the age of the person was given to be 70 years of age. The second feature that was given in the recent NEET PG question was the value of urea that was given, and when we were translating it, the BUN was also elevated. So the score of the person was turning out to be 2, and the question simply said, on the basis of the clinical information, that a pneumonia patient, he himself said pneumonia patient, as a 70-year-old pneumonia patient is admitted into the hospital. He gave the respiratory rate, he gave the blood pressure value of the patient. All the descriptions were given. All you had to do was, in that 3 or a 4-liner question, you had to focus on the age group and the elevated BUN and tell whether the treatment of this person would be oral macrolides or intravenous macrolides admitted in the general ward of a hospital. The answer would be IV administration. We can give amoxicillin with macrolides for these patients and it would be given intravenously. Or we can give augmentin, that is amoxicillin clavulanic acid, along with the macrolides, and can give it intravenously to these patients. When it comes to 3 risk factors present here, then it is a ICU based admission. Please remember, curve 65 score is not for choosing the antibiotics. I will tell you what are the antibiotics to be used as well. But at this moment, I want you to remember that decision making for admitting a patient, sending him in a routine ward or sending him to ICU directly will be based on these parameters. Also remember that age alone is not sufficiently a criteria. Suppose in a question only a patient is given to be more than 70 years of age. BUN value is normal. Respiratory rate is normal, not more than 30. Respiratory rate is okay, let's more than normal, but not going more than 30. Like I told you, a respiratory rate of more than 30 here. BP value of the patient is 120 by 80. Only age is more. Then alone, if age is more, then he says it depends on the decision of a doctor. Like suppose this old man is retired from the army, he's a fit guy. Prior to the episode of pneumonia, he says, sir, I used to go for a 10-kilometer walk every day in the park in the morning and I'm fit and fine. Then I can treat him on OPD basis also. But if it's a frail old man, 70-year-old frail man, a known case of Alzheimer's disease or Parkinson's disease, they are more predisposed to falling sicker whenever there's a respiratory illness. So I would like to admit this patient. So he says in Harrison that if age alone is present, then the decision is based on the doctor who is treating the patient, depending on the health of the patient and the comorbidities of the patient. But if it is more than 2 factors, I mean age is also present and either any of the parameters are deranged, like in the exam it was the BUN values that were deranged, then that turns out to be 2 factors, then it is a wise decision to admit the patient and treat the patient with parenteral antibiotics. And now let us read about the common antibiotics which are to be used. And this that I'm teaching you is an update from the 21st edition of Harrison. As far as the management of persons with community-acquired pneumonia OPD basis is concerned. In the previous edition of the app, I've highlighted that for any person, based on the 20th edition, I've told you that in any patient on OPD basis, we can be starting him on macrolides. But now macrolides have been abused. You see, over-the-counter usage in India has so much of disadvantage that we are having a pneumococcal resistance coming up now. So he mentions now that only if your hospital or if your micro department has documented pneumococcal resistance to be less than 25, you can give macrolide alone. Otherwise, in the older edition, macrolide was first line, oral azithromycin. Now he says you need to give a combination of the two. So indiscriminate usage of antibiotics has resulted in this policy shift. And if you want to make it cost economical for the person, you can be using doxycycline as well. Let us now look at if the person is having presence of comorbidity. This is a chap, let me say, who is relatively healthy, can go for morning walks every day, more than 65 years of age with a fast breathing, respiratory rate is 35. Then I'll say, okay, fine. If there are parameters present where respiratory rate is very high, 2 parameters are present, then I can't treat him on OPD basis. Then I'll say, okay, fine man, you get admitted. If age as well as respiratory rate both are elevated, then it is IPD based treatment for the person. But suppose it is only age present and there is no comorbidity, I can go in for oral treatment as well. On the other hand, if age alone is a parameter, then this would be on OPD basis management. Now let's look at if there is a comorbidity in a patient, like he has already been admitted in a hospital earlier and he's received antibiotic in the last 3 months, then we will be giving you a combination of augmentin, that is amoxicillin clavulanic acid, with macrolide or doxycycline. or we can be using respiratory fluoroquinolones. The mnemonic for respiratory fluoroquinolones is light machine gun. L would stand for levofloxacin, M would be standing for moxifloxacin, and G would be standing for gemifloxacin. This is the treatment that you have to answer for community acquired pneumonia on an outpatient department basis. Let us now look at what are you going to do if you are admitting the patient. In inpatient, it is a combination of beta-lactam, like you can be using amoxicillin with sulbactam and macrolides, or you can straight away use respiratory fluoroquinolones in the patient, mnemonic LMG, I've already explained to you. And if there is a recent hospitalization in the person, then you also need to give cover for Staph aureus and Pseudomonas. For Staph aureus, the cover that we will have to use for MRSA is vancomycin, or it can be linezolid. That depends. If it is VRSA, then it is linezolid which is required, and for Pseudomonas, the cover that we need to give is piperacillin and tazobactam. We shall now be doing another question from the previous years, and this is basically to remember regarding the common opportunistic infections that develop in AIDS positive patients and what are the drugs which can be used for prophylaxis and how long should they be used. The question said which of the following statements is incorrect or wrong with respect to prophylaxis in AIDS. Now normal CD4 count is 800 or 1200. You can take an average value 1000, and if the counts go to almost 50% or lesser, that is CD4 count less than 500, then tuberculosis is the commonest opportunistic infection. If the counts go down to 200 or lesser, it is pneumocystis jirovecii. If it is less than 100, this AIDS positive patient can also end up with development of seizures. You are aware that one of the important reasons why an AIDS positive patient would be having seizures is an intracranial space occupying lesion, that is cerebral toxoplasmosis. If the count is less than 50, this person can even go blind. Yes, blind due to Pisa-Pi retinopathy. You always read about Pisa-Pi retinopathy as a fundus finding, that is in patients of cytomegalovirus retinitis. And if cytomegalovirus retinitis is not given in the questions, then you also need to remember atypical mycobacteria, that is Mycobacterium avium intercellulare, which is written in short form here as MAI. Now, if you look at option number A of this question, it says start PCP prophylaxis when CD4 count is less than 200. Makes sense. I mean, that's the time when you get this infection. So I would like to use drugs to prevent this opportunistic infection from occurring. Though he has not asked about the name of the drug, but you are aware and has been discussed that the drug of choice for pneumocystis jirovecii infection is cotrimoxazole, and the same is useful for prophylaxis as well. Now, when should you be stopping these drugs is when the CD4 count of the patient is documented to be more than 350. I would not like to rely on a single report because there could be errors on the part of the laboratory. So I should be having 2 consecutive reports, and the time frame that I'll give here will be approximately 6 months. So option A and B look like correct statements. C says MSC prophylaxis started when the CD4 count of the patient is less than 50. I just told you the cutoff, and that's where the prophylaxis should be started. But when it looks to, or when we look at option number D, cryptococcal prophylaxis started when the CD4 count is less than 150, there are 2 problems with it. First, in the CNS topic, I have discussed cryptococcal meningitis. I taught you the drug of choice is amphotericin B plus fluconazole, which is given for a couple of weeks, but I did not say that you have to continue it to a particular level. Well, what I want to tell you is that in cryptococcal meningitis, you are not supposed to start chemoprophylaxis in all cases. It is only to be started if a patient has had a previous episode of documented cryptococcal meningitis. Like if somebody was diagnosed as cryptococcal meningitis, AIDS positive patient in 2021, and he develops the same infection in 2022, then I will treat the current infection with liposomal amphotericin B plus fluconazole, and then I will start this person on prophylaxis. And how long will I continue the prophylaxis is not when the CD4 count goes up to 350. This value of 350 that I was teaching you is valid for mainly jirovecii and with respect to tuberculosis as well, but not for patients of cryptococcal meningitis, where you can stop prophylaxis when the counts are more than 100. Let me show you a text from Harrison which will give credibility to whatever I am saying. This is what Harrison says for Cryptococcus neoformans. You are supposed to treat only if there is a prior documented disease, that is one. And second, look at the values that are written. He has written may stop. The word is stop, not start. Stop if the CD4 count is more than 100. Right? Now let me go back to the previous slide. Here the words are stop with the values more than 100. Now let's look at what option number D is saying here. Option number D, as you can see, is saying an incorrect statement. The wrong words here are, it is saying started, it is not started, it is stopped, and the problem here is it is written 150, whereas we stop when the counts are already more than 100 in a patient. So this is the correct answer to this question. What he was basically doing was playing around with numbers with respect to the CD4 count and the common opportunistic infections that would be started, but he twisted it with respect to how long would you be using the drugs in the patient. And option number B for this particular question is an additional point which you need to add to your notes, because it would not be present in the regular notes. That is, count once more than 350. That is when, for at least 2 counts, at least separated by interval 6 months, is when the prophylaxis can be stopped. And ideally, situation like this will not arise, because if a person is taking combination antiretroviral therapy, the once a day pill for management of AIDS, which would be having dolutegravir and emtricitabine, most of the time, though they instead of dolutegravir, there can be raltegravir also. So it's dolutegravir, emtricitabine, and tenofovir. These are the common 3 drugs present in once a day pill for AIDS, which will prevent a deterioration like this. The next question that I'll discuss before you will be for ABG. And in this question, there was pH of 7, which means that there is acidosis in the patient. Now for acidosis, there can be 2 problems. Either it can be a respiratory problem where carbon dioxide is more, or it can be a metabolic problem where bicarbonate is less. If you look here, the carbon dioxide of this particular person is lesser. It is not elevated. If it was 60, normally is 35 to 45. If it was, let me say, 60, I could have thought it is a respiratory problem. The first line of the question straight away tells me there is no respiratory problem of this patient. Rather, it is a metabolic problem. The current diagnosis of mine is my patient is suffering from a metabolic acidosis. And now I need to check out for whether there is a compensation or not. To check out for the compensation, what we do is that we use Winter's formula. The Winter's formula would be 1.5 into the value of bicarbonate, whatever is given in the question. Like in this question, it is 10. To this, you would add a value of 8 plus minus 2. So whatever is the mathematical value that is coming, if that mathematical value that I'm teaching you here is for the expected carbon dioxide, whatever you calculate from this formula, if the mathematical value turns out to be the same as given in the question, if I can hit a value of 30, that means there is compensation working. Option A says metabolic acidosis with respiratory alkalosis. I can answer this question only if, as option number A, if expected CO2 of the patient, which I will calculate on the basis of this mathematical formula, is matching with the actual PCO2. The actual PCO2 of the patient is 30. If both these values from the formula and the actual that is given, if both these values will match, that is when I will say compensation. If they are not matching, it is a mixed disorder. Now in the current edition of Harrison, he is not using the Winter's formula, but he is using the modified Winter's formula. What is modified Winter's formula? He says expected carbon dioxide is simple bicarbonate plus 15. He is trying to make life easier for us. The bicarbonate of this patient, as given in this question, is 10. So if you will add 10 plus 15, it will turn out to a mathematical value of 25. This is the expected PCO2 of the patient. If this was the value given in the question, I would have said, okay, this is option number A. But because the value is turning out to be lesser, it is not compensation. So first and foremost, I need to understand what is going on in this patient. 25 and 30, both are not matching. Since the values in this particular case are not matching, it means there is no compensation present in the patient. Rather, it is an example of a mixed disorder. When I say mixed disorder, this patient is having acidosis of 2 varieties. It is metabolic acidosis with respiratory acidosis. And before I put a mark on that, let's look at 3, that is respiratory acidosis. If it was respiratory acidosis, then carbon dioxide should have been elevated, no? That I ruled out immediately. So I have now at this juncture ruled out 2 options before you. Let's look at 4. Metabolic acidosis with a metabolic alkalosis. Now this is a situation, a combination of metabolic and metabolic alkalosis requires calculation of a delta gap. In delta gap, what we do is that we calculate the change in the value of the bicarbonate as well as the change in the value of the anion gap. In the numerator will be the change in the anion gap, and in the denominator will be the change of the value of the bicarbonate. In this particular question, I'm not going into the calculation of the delta gap, but because I can work out simply the fact that the PCO2 of the patient is turning out to be lesser than the actual value, it means that the person is not being able to do a proper justification for compensation. That would be occurring because there could be a respiratory insufficiency also developing in this case. The correct answer for this question would be option number beta. And usually the scenario that is given to you in the actual exam with respect to metabolic acidosis and alkalosis will be a case of CKD with vomiting. In this particular case, I can say that if I look at the situation given, the CO2 of the patient, suppose the CO2 of this patient was normal. Suppose in this MCQ, I'm not saying 60, suppose it was normal, then I will say it is a case of uncompensated metabolic acidosis. Why? Because normally in metabolic acidosis, there should be a respiratory compensation. The patient should hyperventilate. If the PCO2 was given to be 35, it is uncompensated metabolic acidosis. If it is lesser to 25, the one that I calculated from the formula, then you will say, yes, it is metabolic acidosis with respiratory alkalosis. But because in this question, this value is not matching, therefore this would be a metabolic acidosis with a respiratory acidosis. The correct answer for this question would be option number 2. This is the second example of mixed disorder that I have discussed before you. And my request to you at this particular junction would be that if you're finding this question hard, then there are 2 videos on ABG, very short videos, very precise. For previous 3 consecutive NEET exams, including FMG exams, ABG questions are asked. I have not discussed those same mathematical questions here because otherwise it will unnecessarily drag those discussion. I mean, there's no point of repetition. So my request to you at the moment is that I would like you to go and listen to those ABG based 2 videos which are currently present in the main section of the app that will help you score even better, though those tricky ones are the ones which I'm handling here before you. Now next I'll be talking about the topic of COPD. In COPD, we always have a gold classification given where we classify the disease as mild, moderate, severe and then very severe. Nobody has a problem remembering mild, moderate, severe, but people have problems in remembering very severe one. So most of the time when you go through this classification, you will notice that the values are decreasing. He will always say FeV1, that is, this is timed vital capacity. FeV1 FVC ratio that we talk about is timed vital capacity. Timed vital capacity is always reduced in cases of obstructive airway disorder, whereas it is normal to elevated in restrictive airway disease. But now we are not talking about timed vital capacity. In all 4 varieties of gold 4 mild, moderate, severe, very severe categorizations, in all of them timed vital capacity will be lesser. And when I give bronchodilators to the patient, there will be no improvement also. But we will now look at the fall in the magnitude of FeV1. If it is between 50 to 80, it would be called as moderate. It is 50 to 80, that is moderate. If it is 30 to 50, it would be severe. If it is less than 30, people end up in the actual exam answering this as severe. You will not answer it as severe. You will say this would be a very severe with respect to, the COPD severity. And then what we do is that we also evaluate the level of difficulty in breathing in the patient, not with respect to NYHA, that is not New York Heart Association classification or grading of dyspnea like in heart failure, but what we are using here is called as MMRC, that would be a Modified Medical Research Council grading of dyspnea. Let's look at it. In grade 1, I will say that the patient of COPD will be having breathlessness on climbing up an incline or maybe going up 1 flight of stairs. But if you compare this with a patient having grade 2 dyspnea, this person is taking an evening walk with his wife who's at the same age as him when he's walking in the park. He will say that I always walk slower as compared to other people of the same age group. So maybe a couple of old men are taking a walk in the park. This guy will be the slowest of them. When I compare the slowness of this patient is compared not with his grandchildren, but rather because grandchildren would be running, playing around in the park. It would be compared with peers, which means people with the same age group. The guy is slow. But if you compare with 3, then there will be a stark difference. The stark difference would be like this. The old man that I'm describing now takes a few steps, then stops. After stopping, he will rest. He will rest for a few seconds. But even if you tell him, no, sir, please try walking, he says, no, I'm too breathless, let me rest. So he will maybe rest for 2 minutes. He'll keep on standing maybe if you don't offer him a chair. Then he will again walk few steps, and this time you motivated him to walk a few extra steps, and he's just putting up his hands and saying, no, doctor, I just can't. I mean, in spite of your best motivatory supports, this guy will say, I can't. He will again stop down to rest. The difference between MMRC grade 2 and grade 3 would be the grade 2 person will walk slowly. He will obviously be out of breath, but at least he won't stop in between to catch his breath. But in grade 3, the person will stop in between to catch his breath. And when I look at grade 4, I mean, this guy, let me say in the spring season, there are a lot of flowers, right? So I told the COPD patient that, sir, it's springtime or it's autumn time and there are a lot of flowers present in the park. Why don't you go out and have a look at that? I want him to mobilize a bit. He is maybe on low flow oxygen with help of nasal cannula or nasal prongs. And I found that the person is unable, he's unable to get up. Not that he has paralysis in the legs, but he refuses to mobilize, in a sense that he's so breathless that in this particular case, he even says, sir, forget about going out in the park. He says from his window, he says, sir, I can see the trees, I can see the birds, and I can see the beautiful flowers of the spring season. But I don't have energy in my body to go out because of low oxygen saturation. He says, sir, forget about you asking me and motivating me to go out. It looks nice when you are telling me, doctor, but I feel breathless on even going to the bathroom. He says, for me, getting from the chair, and suppose if I have to change my clothes, I become breathless. If I have to take a bath by myself, I tend to become breathless. So that would be the level of disability in patients of COPD with respect to MMR grade 4. And what we are doing next is that we are checking for two things: the exacerbations that occur in COPD, it could be once a year, twice a year, and I'm simultaneously taking into consideration the MMRC grade of the patient. So let's take up a scenario where I have a patient who is MMRC grade 0 to 1, which means that either he's breathless on climbing stairs or maybe walks slowly, and he has had only one exacerbation or 0 to 1 exacerbation in 1 year. Then I can be starting this patient on a bronchodilator. But if it is gonna be, let me say, MMRC equal to or greater than 2, right? So there's a fundamental difference. In this case, when I'm saying 2, that means he has to catch his breath. Then in this patient on a continuous basis. Here in group A, it is need basis. It is on need basis. Whenever required, you can give it. But in B, it would be on a continuous basis that either of the two, LABA or LAMA, will be required in the patient. If it is group C, now group C would be a person who's having more number of exacerbations. If a patient is having a higher number of exacerbations, then LAMA will be the main drug that would be used. In fact, if they ask you which of the following drugs is recommended in patients of COPD apart from oxygen, you see mortality reducing drug. The main drug that reduces mortality in patients of COPD is low flow oxygen. But after low flow oxygen, the next drug which improves the quality of life of these patients or reduces mortality should be answered as LAMA. I mean, oxygen, if you are considering as a supportive mechanism versus drugs, I mean, oxygen is also a drug, but by drug I mean medicine, right? The routine pharmacological drugs that you study. Then on comparison between LABA, LAMA and steroids, it is LAMA that is required. The importance for those of you who have listened to the older version of the app is that this is a 2021 update. You will notice that in the older version of the app, in group C, we were talking about steroids also. But now he has shifted the position of the steroids to group D. Group D would be a person where you can remember 2-2. What I mean by 2 is, that is MMRC is at least 2. That is, when I say MMRC is 2, that he is very, very slow. And at the same time, or even more than that, right, maybe going up to 3, that he has to stop in between. And at the same time, he has had at least 2 moderate exacerbations or at least 1 exacerbation which is requiring hospitalization. Right? In the previous scenario, when I was saying exacerbation, there was no need for hospitalization. You managed the patient at home only, or maybe came to the casualty but was discharged. He was not admitted in the hospital for a few days. But if he's had a hospitalization, then I need to use a combination of either of the two. The combination that will be used will be LABA plus LAMA, or the combination that would be used would be inhaled corticosteroids with LABA in the patient. If both are given in the question as given in the textbook, first LAMA with LABA combination should be answered, then inhaled corticosteroids. The learning for you is that if he is going to give you this table, he is not going to give you this MMRC grades and exacerbations or hospitalizations. He will simply say in a group A patient. Please remember, previously what I was teaching you was grading of dyspnea. Grading. Now I'm not talking about grade, I'm talking about group. So grading and grouping is not meaning the same, in a sense that when I'm talking about the grading of dyspnea, I also am taking into consideration the exacerbation component also. This exacerbation and the grading combination has been utilized together to make a 2 by 2, and these two have been utilized to make a 2 by 2 table where these various groups have been created, and in group number D it is inhaled corticosteroids that would also be used. The next topic that we shall be discussing is pleural effusion. In pleural effusion, one can ask you that what is the minimum amount of fluid that can be clinically detected. When I was describing the topic of ascites before you, I told you that the minimum fluid that should be present for clinical detection is at least 1.5 to 2 liters. I did speak about puddle sign. Puddle sign can pick up as little as 100 ml, but you need a very high index of suspicion to be able to do a puddle sign, because in routine physical examination, whenever we do a per abdominal examination, we don't do a puddle sign on a routine basis. So it is that the minimum amount of fluid in the peritoneal cavity for detection of ascites is 1.5 to 2 liters, whereas the minimum amount of fluid in the chest cavity for a pleural effusion to be present for clinical detection is 300 ml. The finding that would contribute to obliteration of the hemidiaphragm, and I'll show you X-ray corresponding to that, would be approximately 500 ml. And if he says what is the best test for diagnosis, then I know that in radiology they will tell you ultrasound chest. I agree to that and I respect that also. But you see, ultrasound is a operator dependent technique. CT film would come out and then anybody can evaluate that. Ultrasound is at that particular point of time, and if the probe is not kept properly, you easily can miss a minimal pleural effusion. So the best test for diagnosis should be answered as a CT chest followed by ultrasound chest. And if you look at this particular X-ray representation, you will notice that there is a blunting of the costophrenic angle, and at the same time you can also see this Ellis curve that would come up primarily because of the pleural effusion component present here. In fact, it has this peculiar curvature that I've shown here before you. This entire wetness is the fluid present in the pleural cavity of the patient, for which we will subsequently have to go in for a diagnostic or a therapeutic thoracocentesis. Now, what are the characteristics of a pleural fluid? It is usually produced by the parietal pleura at a rate of 0.01 ml per hour. The total amount of fluid, the normal amount of pleural fluid which is present is about 5 to 15 ml, and it is normally clear. The pH is between 7.60 to 7.64. If the pH is less than 7.2, this means that this would be an indication for deploying an intercostal drainage tube. The significance is that if I'm having an acidic pH of the pleural fluid, it means that bacteria are present. Obviously, I'll take into consideration the sugar component, the protein component as well. But low pH, and I'll describe the indications for putting in a chest tube in case of a pleural effusion, even subsequently also. But one of them is pH less than 7.2. Checked, the protein component would be less than 2%. That would be 1 to 2 grams. It would be having fewer than 1000 white blood cells. Why these values are important is because in the exam he can give you a printout of large number of values. So just like you study regarding the CSF normal cells 0 to 4 lymphocytes, there I'm telling you that it could be up to 1000 white blood cells per cubic millimeter, and the protein content would be 1 to 2 gram. But in any patient who's having an exudate, the values that would be given can be double, triple, or even higher than that, because whenever there's an exudate, there is an inflammatory fluid, and exudate usually tends to clot on standing. When it comes to the glucose component is similar to that of plasma. You will notice in CSF, the CSF sugar was 2/3 of the plasma of the blood sugar, but the pleural fluid sugar is equivalent to that of the plasma. That is why sugar is given less importance here. It's mainly the cells and the proteins which would be given importance along with the pH. And LDH values are less than 50% of the plasma values again. Why we are studying this is because I shall now be describing what is called as Light's criteria, hot favorite of examiners, especially in FMG exam, where repeatedly they keep on asking this information, that Light's criteria are one used to differentiate between transudate and exudate, you very well know, but then how to deploy them. So if you find that all these arrows are going as more than, that is more than 0.5, I'll tell you the parameters also, but if you just notice that if these parameters are going like this, more than 0.5, more than 0.6, more than 2/3 of the upper reference limit of the serum LDH of the patient, then you will say that this is an exudate. And suppose if I give you a situation, or if I give you in a multiple choice question these values where all the arrows are less than 0.5, less than 0.6 and less than 2/3, it would be a transudate. Now let's look at the parameters. What you will do is that you will check out the pleural fluid protein, and then you would divide this by the serum protein, If this value turns out to be more than 0.5, it means inflammatory fluid. If it is less than that, it means it is mainly due to either change in hydrostatic pressure or a decrease of oncotic pressure, which would be transudative variety of pleural effusion. LDH values, as I told you, are almost 50% of the plasma values, but if they're more than 0.6, that is more than 60%, or another expression would be 2 by 3 of the upper reference limit of the serum values. That is when we'll consider that this is an exudate. Even when you take out the fluid in a syringe, no, exudate usually clots on standing. Transudate is just like water. Exudate tends to clot on standing, but I'll not rely only on the physical appearance of it or the physical characteristics of it. I need to have a biochemical evidence, and Light's criteria are not very accurate. 25% cases, Light's criteria can misdiagnose exudate as well. He says in Harrison, this line is there that Light's criteria are not very accurate. In 25% of cases, chances of misdiagnosis of a transudate as an exudate or vice versa is a possibility because of one laboratory error, and secondly that these parameters may not be satisfied in all the inflammatory conditions, but still because they help us, we are going to use them anyway. And now let us look at what will be the site at which we shall be doing thoracocentesis. The preferred site for thoracocentesis will be decided by ultrasound, because lots of time there can be a loculated pleural effusion as well. So the best way is to always first check out the site of fluid with respect to ultrasound, but then you will simultaneously use your clinical judgment as well. You would be doing the percussion, and you will be checking for the site of stony dullness also, which is one of the characteristic features. And you need to poke the patient not in the mid-axillary line. Do not answer in the mid-axillary line, but if this is the scapula of the patient, then I can call this as the scapular line, and this I can say is the posterior axillary line. We have an anterior axillary, a posterior axillary line. So when I poke the patient, it would be somewhere between the scapular, just medial to the scapular and a little lateral to the posterior axillary line. And this would be the 8th intercostal space where I'll be doing it. Though I said the ideal site would be decided on the basis of ultrasound, but in case you are not given ultrasound option in the exam, then you are gonna do this in the 8th intercostal space, just medial to the scapular line. Do not answer mid-axillary line, which is a common error that we make. In fact, mid-axillary line is utilized for, especially 8th intercostal space can be utilized for doing a liver biopsy, but we are talking about a thoracocentesis at the moment. Also remember that when you introduce the needle, you are supposed to go across not only for giving local anesthesia, but when you are progressing your needle also, the needle should be going just above in the pleural space. It should be going just above the upper border of a rib of an intercostal space. Like suppose you have this is the let the green thing go off, and I'll say again, if this is the intercostal space that I'm talking about, then would you like to put the needle in the upper part of the space or the lower part of the space? Then the point is, I will put it in the lower part of the space, or I can say the needle has to go like this against the upper border of the lower rib. Why that is so is that if I put the needle in the if in this particular space, if I put the needle here, it will hit the neurovascular bundle. You see, by anatomy, I'll zoom it in for your convenience also. You can see the rib here, and along with the rib, you can also see the neurovascular bundle present. This is the neurovascular bundle which is present inferiorly. So if you're gonna put a needle which will be put below this particular lower border of the rib, you would hit or go via the artery, and you can cause bleeding as a complication also. So you are supposed to not breach this neurovascular bundle. The anatomy to be remembered is the neurovascular bundle would be present on the lower border of every rib. As a result of it, what you're supposed to do is, whenever you're giving local anesthesia and whenever you're progressing your needle for thoracocentesis, it should be going on the upper border of every rib per se / lower border of the intercostal space. I said two things, both mean the same: upper border of the lower rib / the lower part of the intercostal space. Both imply the same for performing thoracocentesis in this patient. Now he can also ask you that when would you be putting a chest tube? Then one of the indications for chest tube is empyema. Empyema would mean pus in the pleural cavity, especially if it's a loculated pleural effusion, then chest tube is required. pH of the pleural fluid normal, I told you, is between 7.60 to 64. If it is less than 7.2 acidic, it means an infection component, so we need to go in for a thoracocentesis. Pleural fluid glucose, if it becomes lower, If there's a positive gram stain or a culture present or presence of gross pus, I mean point number 1 or point number 5 would basically mean the same, in a sense that empyema can be without loculations also and can be with loculations also. Now if you look at this image which is given, and let me do some markings here. The markings would be in the following sense that the first X-ray that I'm showing you, you can see that the costophrenic angle of the patient is obliterated, and we can see this concavity present, which would be called as Ellis curve, which gives credibility to the diagnosis of this patient as presence of a pleural effusion slash a hydrothorax. But if you're looking at the second image, which is currently on the slide just adjacent to it, then you can notice even here the whiteness is present, the blunting of the CP angle is very much present, but there is no Ellis curve, but it is a straight line which is present. If they give you an image like this, then this would not be a hydrothorax, but your answer would be given as hydropneumothorax. So there are two things present. There is water also present and air also present simultaneously. On the other hand, another X-ray that I'm showing you would be showing a dramatically opposite finding, which is that one that I've described currently before. You're not saying blunting. This I'm going to call as a deep sulcus sign. Apart from deep sulcus sign, you can also notice that this particular lung is more black than normal. There is a clear-cut absence of vascular markings. Normally, you can see at least some blood vessels in the lungs which will appear white, but in this case, there is complete absence of vascular markings. Contrast this with the contralateral side where vascular markings can still be made up. The combination of the two would make your diagnosis. I think all of you have been able to pick it up. What I'm talking about in this case is a standard X-ray which is repeated in almost every exam, similar to the gas under diaphragm X-ray. That would be pneumothorax. For management of pneumothorax in a patient, if he says tension pneumothorax, then you will have to use a wide bore needle so that you can decompress this. The controversy for this wide bore needle is that in Harrison it is given second intercostal space, and in ATLS it is given as fifth intercostal space. So if he uses the word ATLS, then your answer is fifth intercostal space mid-axillary line. And the advantage of that would also be that if it's a soldier with a bulletproof vest on, the bulletproof vest is in the front and on the back, so you cannot go via the vest and access the second intercostal space. So you can raise the arm of the soldier. Bulletproof vest would not be on the side, so you can access the mid-axillary line, and then subsequently in the patient a chest tube would be deployed. But immediate management for the patient would be a wide bore needle which is to be put in fifth intercostal space mid-axillary line, and then subsequently intercostal drainage tube insertion and with the underwater seal would be done in the case. Three very simple standard X-rays: a hydrothorax, a hydropneumothorax, and a pneumothorax is what I've shown you. And empyema is an indication for putting in an ICD, or you can write the word loculated empyema. Both of them are indications. Next, I'll be describing GINA guidelines for asthma for you, which is a reversible airway disorder. When you give salbutamol to an asthmatic, you will notice that the FEV1 of the patient will increase by minimum 12%, or instead of 12%, he can give a mathematical value of 200 ml increment. Now, in earlier times when I was a student, I always used to read regarding SABA, that is short-acting beta-2 agonist, repeatedly used in an asthmatic. But currently, there is a gross change in the guidelines. Earlier, we were saying that SABA is for acute exacerbation. That is okay, but what we found was that the repeated use of SABA indicated poor control and showed an increased mortality as well. There was a higher incidence of mortality with asthma exacerbations with SABA. So currently, we are not using SABA, but we are rather using formoterol with inhaled corticosteroids as a reliever. If he says which drug reduces mortality in asthma, like in COPD, I was saying mainly it is low flow oxygen. If he says what is the main drug that reduces mortality in COPD, it is low flow oxygen followed by LAMA. In contrast, when it comes to asthma, the drug that reduces mortality is inhaled corticosteroids. When you read about the pathophysiology of asthma, you will read about type 2 and non-type 2 inflammation. What I mean by type 2 inflammation is that this would be having a special variety of T cells which would be written as Th2 type of cells. You see, whenever you read about CD4 cells, no, you read about Th1, Th2, Th17, Th9. I'm talking about not Th1, not Th17, not Th9. I'm talking about Th2 subset of cells of CD4. And these are the ones which are responsible for producing those critical cytokines which cause worsening of asthma, exacerbations of asthma. Though we now have drugs which can neutralize them, but interleukin 4, interleukin 5 and interleukin 13 are one of the important villains for pathogenesis of especially what we call as type 2 asthma or called as type 2 inflammatory subset of asthma. Here is where pharmacology also comes in, and lots of time you will be noticing that in patients who are not responding to conventional drugs, we might have to use anti-IL-5 drugs like mepolizumab or benralizumab as well. Type 2 asthma is an important subtype. Mainly you need to remember the data that are put in the red box here with respect to cytokine number 4, 5 and 13, and they have to be neutralized. Now in earlier times, as I was telling you, the reliever medication was SABA. In the older guidelines we used to study acute exacerbation, reliever is SABA. But now he is saying that the reliever which is to be used in all the steps in management of asthma is inhaled corticosteroids and formoterol. The formoterol will act rapidly and inhaled corticosteroids will reduce the airway inflammation component. There are two things, one is reliever, one is controller. Controller would mean prevent the development of symptoms in a patient. Reliever would mean exacerbation is to be neutralized. By controller, my objective is to prevent the requirement of ICS formoterol. In step 1, when I say none, the none does not mean that nothing is to be done. It means that as need basis, like suppose a person is having breathlessness, like he went to a basement, he went to a party in a basement and a child had this problem, then as need basis, inhaled corticosteroids and a formoterol combination can be used and the child will be having a relief of symptoms. And subsequently, if he is not responding to this as need basis, then on a regular basis, he would be started on low dose inhaled corticosteroids. If low dose inhaled corticosteroids alone are not working, then we'll make it a combination of low dose inhaled corticosteroids with formoterol. Your query would be, sir, you were talking about ICS formoterol even earlier also. So what is the difference? You see, earlier I was saying that if person is having worsening of symptoms, that is when. If he's having an exacerbation, that is when I'll be using this drug, but I'm not going to use it on a daily basis. But if a person is having a repeated exacerbation, then I might have to use a combination on a regular basis. So the difference here is for step 3 is that I am having to use on regular basis a combination, in contrast to step 2 where I will be prescribing on a regular basis low dose inhaled corticosteroids. If it is not improving, I will upgrade the strength and potency of steroids. So this would be a medium dose inhaled corticosteroids. Still not improving, I will be using a medium dose inhaled corticosteroids, LABA, plus I will be adding LAMA. So here ipratropium and tiotropium would come up. And in the previous version of the app, you will notice that I was talking only till step 5. There was no step 6. But now he's included a step 6 separately in the current 21st edition of Harrison. He has mentioned a step 6 in which he's talking about either omalizumab, anti-immunoglobulin E, or anti-IL-5 molecules, which I was talking about earlier, or anti-ILR 4 receptor antagonists which are to be used. So the point is that this is a step-up therapy which is to be used. And what is the guide? I mean, how do you decide whether person requires step 1 or how do you decide that he requires a step 3? The bottom line is control. And when I say control, the control would be like, I would like symptoms to occur less than 2 times per week. Especially nighttime awakening. I mean, if a child is awake at night, he won't go to school, he will be drowsy. So nighttime awakening to be less than 2 times per month. Use of reliever medication would be less than 2 times per week, less than 1 exacerbation a year, can do daily activities. I mean, I'm not being very rigid, but I can say that if a child can go to his school and play around, if a child is having less than 2 episodes of nighttime awakening and the symptoms are occurring, okay, maybe once a week, I'm okay with it, then I will continue with whatever medication that I'm giving him. In most cases, it will be as need basis. But if any of these parameters, I'm not saying that all of them should deteriorate. Like suppose the child is not able to do daily activities because he's sleepy, is missing school, absenteeism in the school is increasing, then I need to upgrade the medication from low dose inhaled corticosteroids to low dose ICS plus formoterol. If in spite of this there is no improvement, then I need to keep on upgrading here. So the decision to upgrade here will be clinical and will be based on these parameters that I've described before you, which are a small table in Harrison. Goals of asthma therapy, let's try to remember them. Symptoms we are talking about, right? I would like the patient to be having minimal symptoms. So the denominator should not be month. I should keep the denominator as week, less than 2 times per week. For nighttime awakening, I'm keeping a broader range, less than 2 times per month. It's not that he'll try to confuse you with these data. It's just to tell you and sensitize you to the fact that whenever you are talking about asthma control, the denominator in majority of situations would be kept as per week only. For most of them, no symptoms, use or reliever, less than 2 times per week. Only thing is that is 1 month is a nighttime awakening component. So if all of these are achieved, that means that your treatment is working just fine. You can even plan a downgrade in the patient. But in case any one of these is deteriorating, then you need to upgrade the treatment. And more importantly, in the exam, the most important change that has happened is that earlier we used to study like LABA and LABA for as a controller medication for prophylaxis and SABA for reliever. Now you will notice that there is nothing like SABA. It is because SABA, as I told you, has, if SABA is being used repeatedly, it has rather surprisingly shown increased chances of mortality. It means poor control. And obviously, especially in children, it is very important that you teach the mother the usage of the inhaler properly. And if the child is smaller, less than 7 years of age, then a spacer has to be attached. And especially if it is an infant, then with spacer, even a face mask has to be attached. Otherwise, the drug delivery will be affected. So majority of cases that you get of poor control are the ones where there is either a non-compliance or poor inhaler technique. See, my point is, before you decide that, okay, I'm going to upgrade from low dose to medium dose steroids in a person, I will first have to check whether the person is compliant or not. And most importantly, I will have to check the inhaler technique. So half the time when you sit in an asthma clinic, all you're doing is educating, and your nurse is also doing this, educating the patients with respect to correct inhaler technique. Majority of cases, you don't need an upgrade. In majority of cases, it is just correction of the technique that will help in optimal delivery of medicine to the lung. And this is only for those cases where you have ensured that the compliance is there and the technique is not a problem. The query that I get from lot of students is, like we have to prescribe also. This slide has no bearing on your exam performance. Nobody will ask you the dosages, but then these are the common puffers that you use now, like Budicort you'll be using. So what is low dose, what is moderate, what medium dose, and what do you mean by high dose in corticosteroids is. I've just shown this table only for familiarization part, because lots of time you sit in OPD and you might be giving these puffers. Now next is my patient of asthma, and this asthmatic patient has come to me. Why? Because he's having brown color / black color sputum plugs. I mean, first time when the patient came to me, I was like, are you serious? And he took out a tissue paper and he said, yeah doctor, on the way to the clinic I was having these coughing bouts, and when I was coughing, I was feeling as if something is stuck in my chest, and when I coughed vigorously, this sputum plug came out. And the sputum plug was a horrible brownish. I mean, sputum, lots of time, like if you have a bad throat, that sputum might be sometimes greenish also, some part of it. Or you blow your nose, the greenish thing that comes out. It looks so bad, right? This guy is saying, I coughed out a sputum plug. It was not greenish or yellow. It was almost brownish black. He's a known case of asthma / he's a known child with cystic fibrosis. In this patient, there is a hypersensitivity reaction. There is a hypersensitivity reaction to this fungus by the name of Aspergillus fumigatus. So most of the questions of ABPA, the direct hint will be that an asthmatic child or asthmatic adult came with brownish black sputum plugs. The sputum is thick, tenacious, shortness of breath. So 2 and 3 are standard features of asthma also. But point number 1 that I've written is something that you need to, listen to your patients carefully. And now you'll be doing a workup of this patient. So standard workup will be showing spirometry, showing a flow volume curve, or a spirometry showing obstructive pattern with FEV1, FVC ratio less than 0.1. You did a eosinophil count that is elevated. The HRCT of this patient will be showing a special finding which you don't read anywhere else, that is central bronchiectasis. And then you will be doing some special tests. These special tests that I am writing here before you are the important diagnostic criteria. 3 important diagnostic criteria for answering this topic are immunoglobulin E for Aspergillus. This would be the cardinal test. I mean, because we are having an allergic reaction related to fungus, so IgE for Aspergillus, allergic antibody for Aspergillus is the cardinal test. Total immunoglobulin E values would be grossly elevated, more than 1000 international units, and there would also be a positive skin prick test. So normally we read about skin prick tests being out of vogue, like we used to read about Cassoni's reaction, but now we are talking about a important positive skin prick test, which is important diagnostic criteria for a complication that is caused by this fungus, that is allergic bronchopulmonary aspergilloma. Lots of time you might even read this term, which is by the name of fungal asthma. These 3 criteria must always be present. Now suppose you are having, let me say, only one of these criteria, the ones which I put a star mark against. I'll repeat them again. IgE antibody to aspergillus, total IgE values more than 1000, and positive skin prick test. Suppose you encounter a question in which out of these three only two is present, or maybe one of them is present, then you are gonna call it a severe asthma with fungal sensitization. We use a special term, we don't use it ABPA. ABPA is allergic bronchopulmonary aspergilloma, and a variant of it is called as severe asthma with fungal sensitization. Look at the surprising term that I'm teaching you, fungal asthma. When you read this fungal asthma, the impression in our mind is that, okay, it's an infection. Guys, ABPA is a hypersensitivity reaction. It's a hypersensitivity reaction to the fungus. So we are to use two things for the management of these patients. Yes, we will use antifungal drugs, but in these patients, we also use steroids. We use prednisolone. Oral steroids are being, when I was speaking about asthma routinely, I was not talking about steroids, no. But now, and I was talking about inhaled corticosteroids. I did not talk about oral steroids. But here we are giving oral steroids to the patient, and we are using antifungal drugs. If he uses the word allergic bronchopulmonary aspergilloma exacerbation, then I have to give steroids along with antifungals. The antifungals that are given are like itraconazole and voriconazole and even fosconazole in some of the books. So they will not bother you with the antifungal drugs because they know you will answer it. He will mainly ask you in the exam, what is the treatment for exacerbation? The answer would be given by you as steroids. If exacerbation word is given, don't answer it as antifungal drugs, which are anyway given routinely. And these important diagnostic criteria for ABPA, the ones which are put star marks against, are the ones which are to be remembered. I mean, the surprising term that I described before you was fungal asthma and is very repeatedly asked in the exam. In conjunction with this, there is a possibility that he might give you a slide also, and he has done that multiple times. Like because I have already talked about an asthmatic having a hypersensitivity reaction to aspergillus. In this slide, what I'm saying is, let me say a COVID-19 patient, he was on steroids and he developed a fungal infection. Now you very well know there can be multiple fungal infections that could be occurring. It could be mucormycosis, it could be aspergillus. So how am I gonna pick up that this particular case? The first slide is that of, out of the three slides that I'm showing you, which slide is that of aspergillus, which is that of mucor, and which slide is of which is having melanin present. You can see one which is black. So one, I think all of you know from your microbiology classes that the word black fungus is a misnomer. I mean, the media called black fungus for mucormycosis, which produces a black growth in the nose and in the sinuses and can go in the brain as well. And for diagnosis of that, you need a nasal endoscopic biopsy. So the point is, the one which is having this black appearance, the melanin being produced, is called as demitaceous fungi. It's not mucormycosis. Now, mucormycosis will usually be having this thick aseptate hyphae. In this particular slide that I've zoomed in, you can see aseptate hyphae with the very minimal branching present. So this would be for mucor. This would be for mucorales. And they simply asked what test could be used to identify mucormycosis, and this times NEET PG 2022. And people answered that we'll be putting in a swab and we'll take a sample. See, if the growth is in the sinuses, the swab will not work. So it is a nasal endoscopic biopsy. I mean, what am I doing here is that I'm not using a swab. I'm not going in for a routine culture. It's a nasal endoscopy and a biopsy. And the sample will be sent to the microbiologist and he'll be able to pick up this aseptate hyphae. But if you look at the superior diagram, you will notice that the branching that is occurring here is at acute angles. So in this time, I'm showing before you relatively thinner hyphae. Along with thin, they are also branching at acute angles. The answer for this one would be given as aspergillus. Aspergillus was wrongly labeled as yellow fungus, but that is not the case. And then there are varieties of aspergillus also, like Aspergillus niger and Aspergillus fumigatus. Aspergillus niger is the one which is responsible for invasive aspergilloma. If they give you a question that person is having invasive aspergilloma and what is the treatment, then your answer is not steroids, then it is voriconazole that would be used. But if the question says what drug would be useful for ABPA exacerbation, then it is steroids. I repeat once again, in ABPA also mention of steroids is there. Mention of even antifungal drugs is there, but it is mainly because it's an allergic reaction, so we need to give steroids. But in invasive aspergilloma, where the organism which would be responsible is Aspergillus niger. In fact, I write it here, it will look like the slide is for Aspergillus niger. So I'll just say that verbally because the slide is anyway for mucormycosis. And I repeat once again, when I'm going to send this biopsy specimen, I'll obviously send it for culture. Subrods dextrose agar that you study in mycology would definitely be put. But the point is, if I want an early diagnosis, the slide should be evaluated the same day on whichever day you're sending the sample, because I don't want to be late, because the disease will spread to the brain and can cause mayhem. In fact, we lost a lot of patients after COVID-19 who we were able to get off COVID. I mean, the cytokine storm of COVID-19 was over. We had managed them very well with the remdesivir combination with anti-IL-6 agents. But then subsequently, these opportunistic infections came in because we were very aggressive. So their immunity went down. A lot of them were diabetic. So they ended up with mucormycosis/aspergillus. Subsequently, we shall talk about pulmonary embolism, where most of the time they will also help you by giving a CT angiography report. And as you can see, this would be the pulmonary artery of the patient. And bang in middle of the pulmonary artery, you can see a big thrombus. It's in fact a saddle embolus that can be seen here, which is causing a massive pulmonary embolism and would contribute to right ventricular failure. The settings for pulmonary embolism will mostly be a hypercoagulable state. So he could describe a known case of pancreatic cancer, stomach cancer, or he could give you a setting of a patient who's undergone any kind of an implant surgery like a total hip replacement, total knee replacement, where the orthopedic surgeon has done his work very close to the big veins like the femoral vein or the iliac veins. Now, whenever there's a hip replacement going on, I mean, there will be a lot of hammering, chiseling, drilling going on. So the vibrations which are produced by the instruments used by the orthopedician can trigger a thrombus in the big vein like a femoral vein. Post-operatively, what's going to happen is that this clot is going to break off from the femoral vein, going to travel up retrogradely via the IVC into the right side of the heart, and then will enter into the pulmonary artery and will physically obstruct it. There is also possibility that instead of having one large clot, there might be multiple small clots going into the pulmonary artery branches, which would be called as submassive pulmonary embolism. Now, apart from this, hypercoagulable states can also be given. One of the commonest hypercoagulable state that you encounter apart from pregnancy is factor V Leiden mutation. The problem in factor V mutation is that there is a defective binding that is occurring here between protein C and the clotting factors, and because of this defective binding, what happens is that the activity of factor V goes unchecked. I repeat once again, in factor V Leiden mutation, what happens is that the binding between protein C and factor V is defective. As a result of this defective binding, the activity of factor V is not kept under check, and as a result of it, the clotting can occur. Then even in anti-phospholipid antibody syndrome, there are antibodies which activate the intrinsic system of clotting. This activation of the intrinsic system of clotting can again cause clots, not only in the uterine circulation causing recurrent abortions and a bad obstetric history, but even pulmonary embolism can occur in a patient. And anyway, any person, if he's immobilized for a long duration, it could be, let me say, orthopedic fracture. It could be like, this guy was crossing the road, a car hit him on the legs and he fractured his tibia, maybe the left as well as the right one. As a result of it, he was completely bedridden. So there would be stasis of blood in the calf veins because he can't walk, and therefore the clots can then migrate retrogradely towards the heart and cause a PE in the patient. Most of the time, the presentation given to you will be of a geriatric patient, and he will make it sound like MI because he will start describing respiratory distress and chest pain in the patient. The chest pain that actually occurs in this patient is not of cardiac origin, but is of lung origin. What I mean by lung origin is a pleuritic chest pain, because you see the clot is ultimately going to cut off the blood supply to the pleura, and pleura happens to be a pain sensitive structure in the lungs. As a result of it, this person would be having chest pain that will worsen on inspiration. On examination, when I'm going to check out the patient, there would be a increase in the heart rate, fall in the blood pressure. That can happen even with a myocardial infarction as well. But then one of the special auscultatory findings of this condition, which must be remembered, and I'll just use a different color ink to highlight it, is presence of a wide fixed split second heart sound. Now, traditionally, we read about wide fixed split second heart sound in ASD, but wide fixed split sound can also be seen in a massive pulmonary embolism, because now the clot will limit the amount of flow of blood in lungs. You see, normally in you and me, the flow of blood in the lungs during inspiration and expiration can vary. That variation is because more blood comes in the lungs during the phase of inspiration or right side of the heart during inspiration. But now what's happening is that it will not be physiology, but it will be the size of the clot that will be deciding how much blood will be going in the lungs of the patient. Pulmonary edema in this patient, this was asked in FMG exam, would be absent, and that's very easy to understand, because where is the problem in this case? The problem in this patient isn't right ventricle. There is a right ventricular failure. See, pulmonary edema is a feature of left ventricular failure. This person is having a right ventricular failure, so there would be a sudden onset RVF occurring in the person, as a result of which, because less blood is going towards the lungs, less will come to the left side of the heart, and therefore the BP of this person will also fall. So every time you read a crashing patient would mean that there is almost an unrecordable BP. That's the presentation of massive pulmonary embolism. The initial screening test that we can be doing in this patient is a D-dimer assay, which is indirectly telling me that there is a tendency to form clots. If I do ECG, the most common ECG finding would be sinus tachycardia. But if he says characteristic, then your answer would be deep S waves in lead 1, deep Q waves in lead 3, and T wave inversion in lead 3. It would be S1, Q3, T3 pattern. The X-ray of this patient can show some classical signs, which is gonna be Hampton hump, or it could be a Palla sign. In Palla sign, the main problem would be that there would be a selective oligemia, because most of the time what happens is that the clot tends to obstruct the right descending pulmonary artery. So Palla sign is mainly with respect to the obstruction that occurs in descending. Why descending? Because of gravity, the clot will tend to go down. So it is the right descending pulmonary artery that would be grossly dilated in this case, because there's a clot which is causing a physical obstruction. In fact, these signs that I mentioned before you are those for massive pulmonary embolism. If he just writes the word plain PE, it means submassive. If he says massive pulmonary embolism, then you're going to have a Hampton hump and a Palla sign present. If he writes plain PE, that means there are small clots which are going in the lungs of the patient. In plain PE, if he says what will be the X-ray finding, your answer would be normal. I repeat once again, there would be no classical radiological signs seen in a case of routine pulmonary embolism, or it's unlikely to be seen. It's not that they can't be present. I mean, we cannot actually categorize size more than this much is massive and clot size more than this much will cause a submassive pulmonary embolism. On an average scale, I can say that if 50% or more of the pulmonary artery is getting blocked, that means I'll call it a massive pulmonary embolism in a patient. But if it is a shower of multiple small emboli, then I will have a submassive pulmonary embolism, and in majority of these cases, what I'm going to get is a normal chest X-ray, because those small blockages may not be visualized on a chest X-ray. For the management perspective, if you have a patient who's having unrecordable blood pressure, or the systolic blood pressure in the question is given to be less than 90 millimeters of mercury, then you will have to use thrombolysis. In case it is submassive / PE, the submassive word will usually not be given in the question. If there are multiple small clots and you are going to do thrombolysis in the patient, it will rather break the clots into further small pieces and will worsen the case. So in a plain case of PE / submassive pulmonary embolism, we do not use thrombolytic drugs. We rather go in for low molecular weight heparin. Heparin is used in both of them. So in majority of questions, the objective of the examiner would be to check out whether you know that when would you do thrombolysis in a patient. As I said, it has to be a crashing patient with a low blood pressure present. In fact, in these patients, the right ventricle is the one that will suffer, and echocardiographically, that right ventricle will be having hypokinesia that can be picked up by McConnell sign. This is even discussed in radiology and was one of the FMG exam questions. Now, how do you prevent this from happening? Then to prevent deep vein thrombosis, we can go in for using compression stockings and heparin. This heparin is given post-operatively in especially scenarios where a major implant surgery, or let me say gynec surgery, has been done. Because gynec surgery will be, or pelvic surgery, I can say, by gynec surgery or pelvic surgery, I mean that the surgeon is operating near the iliac vein, and whenever you operate in the vicinity of the iliac vein, the risk is chances of development of a thrombus. So if post-operatively we are gonna use this prophylactically, then the chances of DVT will be lesser, and therefore the chances of pulmonary embolism will also be reduced. Most of the time, the question that would be given to you will have some kind of a hypercoagulable state, and a rare hypercoagulable state that I am now adding to this discussion is nephrotic syndrome. If you would have listened to the kidney section, I have said that nephrotic syndrome can be having a urinary loss of protein C, protein S, antithrombin 3. If you have a urinary loss of protein C and protein S and antithrombin 3, then it's a hypercoagulable state. So the question said a 60-year-old lady, known case of nephrotic syndrome, might have been MGN, membranous glomerulopathy. She went on a long distance flight to meet her son in America. When it's a long distance flight like Delhi to New York flight can be going up to 17-18 hours. So if it's a long distance flight in a patient with hypercoagulable state like nephrotic, then there can be chances of development of clots in the veins. And if you ever gone by a long distance flight, there are a lot of announcements made by the flight attendants that move your legs, move your ankles, move your toes a bit, so that when you are going to move around your ankles, the contraction of the leg muscles will squeeze the blood in the calf veins and reduce the chances of stasis. Now, this lady did not follow a doctor's advice. She went on a non-stop flight to US, and when she landed at the airport, she picked up her baggage and she was walking to the immigration counter where she collapsed suddenly. And the doctor on duty, when he examined her, he found he had tachycardia, low BP. He thought maybe she had a MI. But when he auscultated her, there was a wide fixed per second at sound, and there was no evidence of pulmonary edema because mostly we have anterable MI. When he did ECG, there was no ECG findings of MI, rather there was presence of S1Q3T3. Or when the X-ray was done, there was no battering pulmonary edema, but rather there was maybe a Hampton hump or a Palla sign present in the patient. So the message is that any hypercoagulable state, it gives a description like this, your answer would be given as that of pulmonary embolism. Whereas in case you get a question in which, and that's an important one, if he is talking about fracture of the long bone, like this guy had a bike accident and it was a Harley Davidson bike and the bike fell on the leg of this guy. Now, following a bike accident, if after, let me say, 24 to 48 hours, there is a development of respiratory distress in an individual and he also goes into coma, then you have to think in terms of fat embolism syndrome, FES, in a person. And the criteria that are used to remember fat embolism manifestation are called as Gerd-Wilson criteria. This would be one scenario where, again, because I was saying orthopedic implant surgery, at the moment I'm not talking about an orthopedic implant surgery. I'm talking about a guy who had a fracture of the shaft of femur that was repaired. In spite of the best efforts of the orthopedic surgeon, the best orthopedic hospital, best orthopedic surgeon operated on this guy. After 24 hours after surgery, there is a respiratory distress and subsequently there is even a coma as well, because the cytokines that are released here will cause damage to the lung circulation as well as the brain circulation. Then it is FES which is to be considered, for which there is no definitive treatment. Yeah, we do give high flow oxygen to these patients, but usually we find that there is a high chances of mortality with fat embolism syndrome. Similarly, with massive pulmonary embolism, chances of death are very, very high. I mean, in earlier times, massive pulmonary embolism was almost having 100% mortality. But now we are able to identify cases relatively earlier, and we also had a lot of PE cases after COVID-19, because COVID-19 Delta variant was also a hypercoagulable state. So though we got the patients out of cytokine storm, but they later on ended up with clot formation in the pulmonary artery, which resulted in right ventricular failure, crashing of the blood pressure, and we could not do much for those patients. The next topic that we're going to discuss is pulmonary artery hypertension, and usually they will help you with a chest X-ray finding, which is very prominent in this case, which would be that this is the aortic knuckle, and just before that, this protuberance, like I can say, like the handle of a cup that we use to drink tea, there's a very significant pulmonary artery prominence present in the patient. In fact, the contour of the heart also looks a little problematic, because these patients could also be having a concomitant right ventricular hypertrophy. So for pulmonary artery hypertension, if they give you this classical X-ray finding, then it is cool. I have removed the marking so that you can appreciate the prominence of the pulmonary artery segment. But let's now look at what is the definition for pulmonary artery hypertension, because it has changed now. In the older edition of the app and in the 20th edition of Harrison, I was telling you that the definition of pulmonary artery hypertension is more than 25 millimeter of mercury at rest and more than 30 on exertion. But in the current edition, the 21st edition of Harrison, he has mentioned that the cutoff for diagnosis of pulmonary artery hypertension should be a mean pressure of the pulmonary artery more than 20 millimeter of mercury. You will say, sir, what is the difference? Last edition it was 25, now it is 25 millimeter difference. For that you are saying such a great update. Well, my point is that he is saying that usually pulmonary artery hypertension is diagnosed very late. So for us to identify, because the morbidity and mortality with it is fairly extensive, for us to have an early diagnosis, we have deliberately decreased the threshold at which it should be picked up. Normal pulmonary artery pressure, systolic is 25, diastolic is 10. Mean pressure of the pulmonary artery in you and me is 15 millimeters of mercury. If the mean pressure increases to more than 20, you are gonna say pulmonary artery hypertension. And there is another definition that is also given, that the systolic pressure is more than 35 millimeter of mercury. I have told you the normal values 25 by 10, mean value 15. What you are supposed to remember is two values. However, these are normal values from physiology. From the exam perspective, you need to remember these cutoffs 20 and 35, and do take care to remember mean values and systolic values, which are different. Mean values are more than 20. Now, why and how the patient will present to us? If there is higher pressure in the pulmonary artery, less blood will go in the lungs. If less blood will go in the lungs, the person will be having exercise intolerance, and because of the higher pressure in the pulmonary artery, the valve will close with more force, so there will always be a loud P2 present. Now, what's going to happen to the second heart sound? When I discuss in a routine physical class higher pressure in pulmonary artery, people answer wide split. Where is that? No, it's not the case. Now let's look at why. If the pressure in the pulmonary artery is high than the pressure in the right ventricle, you see during systole, right ventricle, because there is a compensatory hypertrophy, so right ventricle will be able to send blood to lungs. But once the systole is done, then the pressure in the pulmonary artery will be higher. This pressure higher in the pulmonary artery will force the valve from behind. It is like as if you're trying to slam the door faster with force. So not only the sound of closure of the door, like if you slam the door, no, the slamming of the door will produce a loud noise. But at the same time, if you push the door from behind, like in this case, the pulmonary artery hypertension, the pulmonary artery pressure is pushing the valve from behind. So that closure is forced and faster. And because it is faster, the gap between A2 and P2 will become lesser. This is what I'm saying. Let me just represent that diagrammatically. Every time I have talked about S2, I have talked about A2 and P2, and there's a time lag of 30 milliseconds. Now what I'm saying is A2 will not have a problem. Obviously, the problem is in the right side of the heart. There is a pressure from behind on the pulmonic valve that, okay, go and close early. So I'm shifting this to left side. I'm shifting this to left side to say that the gap between the two lines will reduce, and we are going to call it a narrow split second heart sound. Because there can be right ventricular decompensation occurring, right atrial hypertrophy occurring. So even a third and a fourth heart sound can be described in these patients. And because of right ventricular failure in these patients, if this happens faster, you see there is a limit to which right ventricle can hypertrophy. After all, at a particular stage, right ventricle will not be able to work, and because anyway, whenever there is a hypertrophy, the oxygen consumption of the heart will also increase. Coronary arteries will not be able to provide an adequate amount of perfusion, so you will be having complaints like chest pain, because hypertrophy, I said, the demand of the heart is more. So they can even be chest pain in this patient, and BP will also be lower because pulmonary artery flow will be lesser. Pressure is higher, so less blood will go to lungs. If less will go to lungs, less will come to the left side of the heart, causing a fall in blood pressure as well. Now, later on, when the right ventricle decompensates, initially it was hypertrophy, later on it will decompensate. That is when there can be a functional TR developing in a patient, which will result in a pan-systolic murmur. So in a patient of pulmonary artery hypertension, you might read about a systolic murmur, that is pan-systolic, that's due to functional TR. Why am I calling it functional tricuspid regurgitation? Is because there is no problem with damage to the valve leaflets. The leaflets of the tricuspid valve are fine, no? Like in rheumatic heart disease, the same valve leaflets are scarred. Here there is no scarring of the valve leaflets. It is simply that the tricuspid valve annulus is dilated, because of which the blood can leak across, and that's why I'm going to call it a functional tear. The next point that I say is very important, especially for those of you who are sitting for ELISAT. If there is an increase in right ventricular and diastolic pressure, you see what is happening is pressure in the pulmonary artery is more, so therefore the right ventricle will also hypertrophy. Right ventricle hypertrophy, right ventricular and diastolic pressure will be increased. This will increase the pressure in the right atria, and if you increase the pressure in the right atria, then all the blood, epicardial venous plexus, no? There are veins which are having venous return to the heart. You see, heart has its own venous supply also, no? The venous return of the whole body comes via the SVC, IVC. But heart has its own epicardial venous plexus, which is connected to the pericardial sag. So what's going to happen is the pressure in the epicardial veins will also increase. Due to increase of this pressure, there will be a pericardial effusion also developing in these patients. So don't be surprised. Traditionally, we read pericardial effusion with patients who are having tuberculosis or with a patient who's having, let me say, a malignancy which is going to the pericardial space, like lung cancer can metastasize to the heart. So there can be a pericardial effusion occurring in a patient. But today I'm not talking about any malignancy or infection. I am saying back pressure changes, higher pressure in pulmonary artery, right ventricular and diastolic pressure is more, right atrial pressure is more, so the blood is not able to enter. The epicardial venous flow will not be able to enter in the right side of the heart, and the epicardial venous flow is responsible for ultimately the pericardial fluid production. I mean, pericardial sac is where the pericardial fluid is present, about 20 to 50 ml for lubrication purposes. Now, this production is dependent on the epicardial venous plexus. If the pressure in the epicardial venous plexus is higher, there would be more leakage or transudation via the capillary bed, causing pericardial effusion. Plus, in some cases, you will read about connective tissue disorders like scleroderma, crest syndrome. So, if there is going to be connective tissue disorder, then features of crest like calcinosis, Raynaud's phenomenon, esophageal dysmotility. I've discussed that in rheumatic, sclerodactyly, telangiectasia. Those features could be present in the patient. In pulmonary artery hypertension patients, you can also notice development of clubbing in the patient. This clubbing is not only seen with lung cancer, though there are a lot of causes of clubbing. You can have endocrine causes of clubbing as well. Even cirrhotic patients can have clubbing. But the point is, even Graves' disease could be having acropathy, which can look like clubbing. My point is, the clubbing is also a presentation not only with lung cancer, not only with infective endocarditis, but even with pulmonary artery hypertension. And now we're going to talk about what is the workup of these patients, where some special points are to be remembered. If he says, what is the screening test for diagnosis of pulmonary artery hypertension? The screening test will be answered by you as bubble contrast echo. Now, the last time I have described a bubble contrast echo before you is with respect to a complication of liver cirrhosis, that is hepatopulmonary syndrome. So 2 times in the entire rapid revision here, I'm talking about bubble contrast echo. One is hepatopulmonary syndrome, not hepatorenal, hepatopulmonary syndrome, and second is a case of pulmonary artery hypertension. If I do an X-ray, I can get a prominent pulmonary artery, features of RBH, obliteration of retrosternal space, but these would be findings that will take some time to appear. So early way to identify will be one, a very subjective method, a 6-minute walk distance test. We used to do a 6-minute walk distance test even in COVID-19. When we were remotely monitoring patients, a lot of COVID patients were at home and they complained that, oh, I think my saturation is dropping, I'm not feeling okay. I said, okay, walk for 6 minutes. Check your SpO2 before you walk for 6 minutes. Walk at a comfortable pace from your drawing room to dining room to your bedroom, wherever possible, in your terrace, wherever possible. At the slowest possible speed, try to walk continuously for 6 minutes. We check your saturation before and after. If there's a drop, it means that your lungs are affected and you need a hospitalization. So similarly, in this case, in the controlled settings, I'll put up 2 cones at a distance of, let me say, 200 meters, and I'll ask him to point A, 2 cones, point A, point B in the hospital corridor, separated by, let me say, 100 to 800 meters, whatever is the distance possible in a hospital, and ask the patient to walk between these 2 points under controlled settings at a relaxed pace, and whatever distance he can walk is to be noted down, because in next visit I'm going to compare the distance that he walked this time from the distance that he can walk subsequently. Now in India, we use this crude method of 6-minute walk distance, but in America they use cardiopulmonary exercise testing. CPET is cardiopulmonary exercise testing, where you will see, a lot of time there would be videos of Ronaldo or Messi doing some exercise, putting on a special mask, and all those tubes coming out of those masks, which are being measured by special sensors. So we call it cardiopulmonary exercise testing, and it's available in our hospitals also, where we check out the peak volume of oxygen consumption, because if oxygen can be provided by the heart, then muscles will produce carbon dioxide. If heart cannot generate, you see, pulmonary artery hypertension, blood supply to lungs is less. So heart cannot, even if the heart is beating normally, the pressure higher in the pulmonary artery is causing a ventilation perfusion imbalance. Actually, the flow of blood to the lungs is less. And because there is less flow of blood to the lungs, therefore, the amount of oxygen coming in the body will itself be less. So if you do cardiopulmonary exercise testing of a normal person like you and me, if I do hard exercise, and I can't do that, my oxygen consumption of the body can increase, because my heart and my lungs are providing all that oxygen. So the muscles will be able to produce the end products also. The tissues will be able to produce carbon dioxide also. But if the heart is not, the heart and the lung combination here is not able to work properly, then the peak oxygen delivery to the tissues will be compromised. If he says, what is the best test for diagnosis of this condition? The best test for diagnosis is an invasive hemodynamic monitoring And nowadays what we do during this invasive hemodynamic monitoring, which I can casually called as cardiac catheterization, is I can do a vasoreactivity test. In vasoreactivity test, which was a question in INISET May 2022, the question was, vasoreactivity test is done for, then we do it for pulmonary artery hypertension, where we give to the patient inhaled nitric oxide. Nitric oxide is a powerful vasodilator, and if we get a positive response, it means that our patient of PAH will respond to calcium channel blockers. If it shows a poor response, then alternative drugs will be discussed in today's discussion, subsequently. But vasoreactivity test can be done during cardiac catheterization itself. When you give nitric oxide, the pressure in the pulmonary artery, if it falls, it's more than 20. But if it falls, it means CCBs should be started. If not, then ambrisentan and other drugs can be used. Lots of time in the exam, you will notice that in the topic of pulmonary artery hypertension, he will also talk about a lung function test, that is DLCO, diffusion capacity of the lung for carbon monoxide. DLCO is less in interstitial lung disease, understandable. No pulmonary fibrosis, so DLCO will be lesser. Every time there is a idiopathic pulmonary fibrosis or there is a respiratory bronchiolitis, inflammatory RBILD, that is respiratory bronchiolitis, interstitial lung disease, the bottom line is every time I'm going to have a pulmonary fibrosis present, DLCO is less. But even in pulmonary artery hypertension, because there is fibrosis in the inner lining of the pulmonary artery and the branches, the delivery of oxygen to the tissues, delivery of carbon dioxide to the tissues is less. Why it is happening? DLCO, why it is lesser is because you read a term plexiform arteriopathy, though I'll mention this term subsequently also from the histopathological perspective in this topic. But whenever you read pulmonary artery hypertension in pathology book, the pathologists use this term plexiform arteriopathy, which means the fact that the blood vessels of this patient would be having a intimal fibrosis. There will be narrowing of the lumen of the blood vessel and including the smaller branches. So if the blood vessels in the lungs are relatively narrowed, then the chances of diffusion across this fibrotic area would be relatively lesser. HRCT is also valuable because it will show you enlargement of the main pulmonary artery segment, a peripheral pruning of pulmonary artery branches. And you see, when I was describing you pulmonary embolism, I was saying clots in the pulmonary artery. Wherever there is a clot, prior to that, the pulmonary artery will dilate. But you can see the clot, no? You can see the obstruction. In this case, it's a universal dilation of pulmonary artery with pruning. Pruning means thinning. The distal blood flow is lesser. So in the periphery of the lungs, the blood supply would be relatively lesser. And yes, nocturnal oximetry. We not only check for nocturnal oximetry even in patients of obstructive sleep apnea. Even if a person is having OSA, even then we talk about polysomnography and we check for SpO2 values when the person is sleeping. A lot of patients of pulmonary artery hypertension might even be having a concomitant OSA component which will worsen the scenario for him. But my point is that nocturnal desaturation not only occurs, in fact I'll just put this in bracket because the impression otherwise will come is this is the finding of OSA. Nocturnal desaturation is not only a feature of OSA but is also encountered in pulmonary artery hypertension. Now there are two main approaches for the management of this patient, and this is the latest data in the 21st edition of Harrison. He says ambrisental tadalafil, there is a 50% decrease in the mortality. Earlier we were using single drugs. Now we are going for combinations. We are either going for combination of 2 drugs or even 3 drugs. If we are using 3 drugs, we are having is a 100% mortality reduction, which looks very enticing, and therefore it looks as if that epoprostenol, bosentan, sildenafil should be answered as the treatment of choice for this condition. But he mentions in the textbook that the current sample size is very small. Because of the small sample size, though the mortality reduction has been very dramatic, 100% reduction, but we cannot take that into consideration. So if in the exam, if they ask you what is the drug management for pulmonary artery hypertension, and a lot of options are given, CCBs are also given, ambrisentan, tadalafil combinations also, then the first answer of yours should be given as ambrisentan and tadalafil, for which multiple trials have been done. Peer-reviewed studies are present which have shown a substantial reduction in the mortality. Now, this is a table which has been asked repeatedly in the INISET exam, and the main feature which I would like to draw your attention is that if in any person of pulmonary artery hypertension, the right atrial size is more than 26 and there's a pericardial effusion, then this indicates a higher chances of mortality. If you just focus on this alone parameter, echo is showing right atrial size of more than 26 millimeter, and there is a concomitant pericardial effusion, and simultaneously in the patient there are other features like repeated syncopal episodes, chest pain present in a patient, heart failure findings. I mean, for heart failure I can also check for the value of BNP, B type natriuretic peptide. Then in those situations, this means that the person would be having higher chances of death, high risk case. In contrast, if the right atrial size is less than 18 and there is no pericardial effusion, though there are other parameters also, but in the MCQ he asked you to select the one where you would be having is a 10% 1-year mortality. If a pulmonary artery hypertension patient is having RA size more than 26 centimeter square and there's a pericardial effusion, there are 10% chances that the person would expire in next 1 year. On the other hand, when it comes to the extreme left hand side, the risk of person dying would be relatively lesser. Now, subsequently, he has also mentioned a WHO classification where he has talked about the various groups of pulmonary artery hypertension. Just to give you idea regarding the various groups and the reason behind it, I can just draw a quick shunt diagram here. Like suppose a person is having a ventricular septal defect. There's a child who's having a VSD which is not treated. So what's going to happen is that the blood will go from the left ventricle to the right ventricle. It will dilate the pulmonary artery. So artery will dilate, but there's a limit to how much it can dilate. Subsequently, there will be a fibrosis, intimal fibrosis inside this artery, and subsequently the pressure in this artery will begin to rise. When that happens, then you can even have a shunt reversal, because once the pulmonary artery pressure will become more than that of the left side of the heart, you could even be having an Eisenmenger complex developing in the patient. My point here is that if there is a pulmonary artery hypertension due to a left to right sided shunt in a person, this would be totally different from, let me say, a patient who's having connective tissue disorder by the name of scleroderma. I mean, you also read about connective tissue disorder like scleroderma, where also there will be a pulmonary fibrosis and a pulmonary artery hypertension developing in a patient. Or let's take up another scenario. A person is suffering from COPD. In COPD, there will be hypoxia. Because of the hypoxia component, there will be vasoconstriction. All blood vessels dilate in presence of hypoxia except one pulmonary artery. Pulmonary artery always constricts in response to hypoxia, and therefore if there is a vasoconstriction, then these patients would be having pulmonary artery hypertension, later can have a right ventricular failure that would be called as cor pulmonale. So if COPD is causing a cause of scleroderma, then there is no shunting present. No? So he has made these groups because suppose it is due to a left to right sided shunt, then we will say group 2 pulmonary artery hypertension. On the other hand, if it is due to intrinsic lung disease, which lung disease could be due to, let me say, the pulmonary fibrosis or scleroderma or emphysematous bullas of COPD, but the bottom line is every time there is a parenchymal lung disease, the standard feature of all parenchymal lung disease would be hypoxia, and hypoxia causes constriction of pulmonary artery, so that would be group 3. If there's a chronic thromboembolic pulmonary artery hypertension, that you need to remember a bit, thromboembolic, then this would be, I would just draw parallels with group 4 and Budd-Chiari. Like in Budd-Chiari, there's a hepatic vein thrombosis. Here I'm saying a thromboembolic process in the pulmonary circulation. Right, that would be group 4. Group 5 is where pulmonary artery hypertension may not always be seen, but let me say if there's a myeloproliferative disorders in the patient, or there is presence of lymphangioliomyomatosis, these rare disorders, or any vasculitis present in a patient, or metabolic disorders like glycogen storage disorder, or any tumor is causing obstruction, then we will call it group 5. Let's revise. Group 2 is going to be L2R shunt, group 3 is going to be lung disease. Group 4 is thromboembolic, something akin to, I can say, Budd-Chiari, though Budd-Chiari is pure thrombotic and I'm saying thromboembolic. Group 5 is like myeloproliferative disorders or rare connective tissue disorders per se, and if there is no cause found, suppose out of all the causes, you are not able to find any cause, then it is group 1 pulmonary artery hypertension. So you can see that group 1 is plain PAH written. It is not IPAH. Earlier you had terms like idiopathic pulmonary artery hypertension, but now it's just using the word group 1 PAH, which means that all other causes have been ruled out. You've done an echo, there is no left to right sided shunt. There is no parenchymal lung disease in a patient. There is no thromboembolic processes associated. There is none of these myeloproliferative or vasculitis kind of conditions determined. Then it is group 1, where you will always read about intimal fibrosis. You will read about these classical plexiform lesions in pathology and the word precapillary remodeling in a patient. These are terms which are to be remembered from pathological domain: precapillary remodeling and classical plexiform lesions. These are groups. This is WHO grouping of pulmonary artery hypertension, and then we use multiple drugs for management of this patient. The decision for which drug is to be used is based on the vasoreactivity testing. The vasoreactivity testing would be done with inhaled nitric oxide. If you are going to get a good response, then you will start the patient on oral CCV as I told you. But if there is no response, then and it's functional plus 3. Functional plus 3 means that person becomes breathless and going to the washroom. Then I will be going in for ambrisentan primarily in this patient or bosentan in this patient. And along with this, I can be using epoprostenol as well. And along with that, even tadalafil. So it is like I have 3 things that I can select here. The 3 things that I've selected are, I'll repeat again, ambrisentan, epoprostenol, and tadalafil in the patient. And the trials that I talked about in the previous slide given in the 21st edition of Harrison, they are mentioned mainly with respect to ambrisentan and tadalafil being used. As far as functional class 4 is concerned, the person is having this known case of PAH, is having breathlessness, dyspnea present, and the dyspnea is so bad that even going to the bathroom in this individual is a big problem. He is wheelchair bound, let me say, or dependent on others for day-to-day activities. Then we will be giving IV epoprostenol in this patient. I mean, he is mentioned, this is the European Pulmonology Journal from where I'm talking about. Then he's talking about 3 drugs being used in a patient, where the first one will be epoprostenol. Why I discuss that is because earlier I just said that the main drug for the treatment of this condition is, and I said, ambrisentan with tadalafil. But now there's a tweak in the question. If he gives you a functional grading of the patient, if he says that he is breathless even at rest, and he says what is the treatment, then don't start with ambrisentan. Then he says with functional class 4, this is NYHA grading I'm talking about. I'm not talking about MMRC now again. MMRC was for COPD. The MMRC grading of dyspnea was for COPD. This that I'm talking about functional class is NYHA. Then the first answer would be epoprostenol. If he says functional class 3, then it is bosentan or ambrisentan. That would be the first line drug to be answered. And if he says a vasoreactivity test positive in a patient right away, then it is oral CCB, SR, amlodipine to be used. The last topic in pulmonology that I discussed before you is hemoptysis. And the most important cause for hemoptysis is change. Do not answer as tuberculosis. I mean, it's okay to say that tuberculosis is a common cause of hemoptysis in Indian population. But then on a global basis, if he says what is the leading cause of hemoptysis, then the first answer of yours would be given as viral bronchitis. Repeat once again. If he says what is the number 1 cause of a routine small volume hemoptysis, not massive. You know, if I'm talking about massive, then it could be bronchitis also. It can be tuberculosis also. But routine, the small volume hemoptysis where the sputum is tinged with blood, the usual routine cause of a small volume hemoptysis is viral bronchitis. With bronchitis, large airway disease, there is a destruction of the large airway, so even the blood vessels become vulnerable and can rupture. If he says what is the leading cause of death in bronchitis, then it is a life-threatening hemoptysis. Then with aspergillosis, I don't mean ABPA. In aspergillosis, here I am talking about invasive aspergilloma. This invasive aspergilloma is Aspergillus niger, which is usually a cause of cavity formation in lungs in diabetic patients. You see, ABPA was asthmatic or cystic fibrosis. Invasive aspergilloma would be like a diabetic or immunocompromised individual in which, or like he could be a patient who has had extensive amount of steroids for Delta strain of COVID-19, and then invasive aspergilloma can intervene and can cause even a life-threatening hemoptysis. As far as tuberculosis contributing to hemoptysis is concerned, then the important issue which is to be remembered by you is that in cases of tuberculosis, the artery that is usually affected is the bronchial artery. And bronchial artery being a high pressure circulation, so therefore there is a possibility of this getting converted into a massive hemoptysis as well. However, he would love to ask you regarding the damage to the pulmonary artery wall as well. You see, pulmonary artery has more connective tissue than the bronchial artery. Bronchial artery and pulmonary artery, if I compare, then pulmonary artery will be having relatively a more amount of connective tissue, and because of more amount of connective tissue, there can be an aneurysm being formed in the pulmonary artery, which is called as Rasmussen's aneurysm. This is itself a question. Rasmussen's aneurysm is found in TB. In which blood vessel? Don't answer bronchial artery, answer it as pulmonary artery. Then Paragonymous westermani. This is responsible for endemic hemoptysis. I mean, traditionally we read about endemic ascites like pyrrolizidone alkaloids in PSM, but I'm trying to teach you regarding endemic hemoptysis in a patient. And I recall there was a FMG question that said that after a marriage party in rural Goa, where seafood was served, After few weeks, all the people who attended the marriage party started having streaky sputum containing blood. What could be the possible reason behind it? So where seafood was served, crabs were served which were not cooked properly, it is Paragonimus westermani. I'm talking about lung fluke being responsible for development of hemoptysis. These are some of the important causes for hemoptysis that are spoken about. I'll talk about cardiovascular and malignancies on my subsequent slide, but let's revise the causes. Viral bronchitis. Bronchiectasis, the question is leading cause of death in bronchiectasis. Don't answer pneumonia, don't answer respiratory failure, don't answer pulmonary embolism, don't answer heart failure, answer it as life-threatening hemoptysis. COVID-19 patient on steroids having life-threatening hemoptysis, aspergillosis, not mucormycosis, right? Mucormycosis would mainly cause a rhinocerebral manifestation. TB anyway is a universal thing. I mean, bronchial artery can be damaged, which can translate into massive hemoptysis, which would be more than 400 ml. I'll give you the definition once again on the next slide. And then with endemic ascites as a endemic hemoptysis, as I explained, it was Paragonimus westermani. Now comes a very important aspect: life-threatening versus non-life-threatening hemoptysis. So every time he gives you a scenario of massive hemoptysis, and he says, what is the treatment of choice? Though I'll tell you what is the sequence. The treatment of choice for massive hemoptysis should always be answered as bronchial artery embolization. Now, if we can identify the site, like if it's a known case of lung cancer or he's a known case of pulmonary tuberculosis, he's already under your follow-up, at least you did a basic x-ray that showed a lesion in the apex of the right lung of the person, then you will try to make him lie on his right side, make the bleeding side dependent in any case of massive hemoptysis, like in case of pulmonary TB where x-ray had already been obtained by you. Avoid putting an endotracheal tube. He says that the original cough reflex of the person is superior than endotracheal aspiration. I mean, normal thought process is we will intubate, we'll put a catheter via the endotracheal tube and we'll suck out the blood. But those clots could actually block the endotracheal tube and choke the patient. So he says, wherever possible, if the cough reflex of the patient is intact, if he can cough it out, let him spit out the blood. But if the person has, let me say, lost so much of blood that he became unconscious, in any unconscious patient, the airway is vulnerable, then you can do selective intubation of the non-bleeding lung that will prevent the blood from going in the contralateral lung. No, one lung is bleeding, but at least I can protect the contralateral lung and can maintain the oxygen saturation of the person. The concept is wherever possible, don't intubate. If you have to intubate, try to intubate the normal lung in the patient so that at least that can be prevented. Meanwhile, you can work on the contralateral lung. Now, what I mean by the contralateral lung is that we have to do a flexible bronchoscopy or a rigid bronchoscopy wherever available. And if we are not aware of whichever side is bleeding, one possibility is known case of TB, cavity in the right upper zone, so you will keep him on the right side. But if he came first time and you are not aware which side is the lesion present, then you have to anyway do a CT and a CT angiography to locate the site. So this in black basically implies that you're not aware of the bleeding occurring from where. Once you have located the site, then you send in a scope. You see, if you send in a scope directly without doing a CT, the surface area of lungs is equivalent to that of a tennis court. It would be like looking for a needle in a haystack. I mean, the source of bleeding, right? The lungs are so extensive, the surface area is so extensive. So I do a CT angiography and then plan a flexible bronchoscopy where we can suction the clot or deploy a balloon catheter and we can put a tamponade effect by which the bleeding can be controlled. Alternative strategy is photocoagulation and cautery. But currently, out of all these approaches that I mentioned, one I told you was that we can go in for a flexible bronchoscopy, put up a balloon catheter and put a tamponade, or using a rigid bronchoscopy, we can go for photocoagulation with cautery. Or the third approach we can go in for is a bronchial artery embolization. Out of the three approaches that I mentioned here, if they ask you to select one, I have already told you the most successful one is bronchial artery embolization, though there is a side effect also because of which the person can become paralyzed for the rest of his life. Paraplegia can occur. That paraplegia is due to anterior spinal artery embolization in the person. Now, if he tells you a situation where there is a non-life-threatening hemoptysis in a patient, then for non-life-threatening hemoptysis in a person, the first investigation to be anyway done is X-ray. But X-ray is usually normal. In majority of cases, there is a possibility that if a person is having a non-massive hemoptysis, though he says, okay, you will do X-ray, complete blood counts, urine study, creatinine study, but in large number of cases, this X-ray will be normal. So if he, in the question, listen to this part very carefully, if he gives you high risk scenario, like if he says 40-year-old man, older than 40, he will himself put high risk features in the MCQ. Harrison says that if a person is having high risk, like age more than 40 and is a smoker, then straight away you should do a CT scan. So large number of questions on non-massive hemoptysis will begin by the data that I have mentioned here. Then you will not answer a chest x-ray, you will straight away mention a CT scan in the patient, because the lung cancer may be so small that it may not be picked by x-ray. You see, x-ray is anyway to be done in any respiratory case, no? But my point is, if the lung cancer is a cause, it can be so small that it may not be picked up on a routine chest x-ray. So if high risk features are present, that's what Harrison has written. If high risk features are present, directly go for CT scan, and that will be the usual scenario given to you and the answer subsequently. And then you can go in for bronchoscopy. I mean, the CT is telling you lesion is on the left or on the right, and then depending on whatever is the requirement, the pulmonologist can decide to go in for either no intervention or go in for a balloon tamponade, or can go in for photocoagulation. But there is no need for bronchial artery embolization for persons who are having, I mean, if it is persistent, then it's a different issue. But in majority of cases, the bleed will settle. You know, if it's a vasculitis, let me say, that is causing erosion of the pulmonary artery, then you have to go in for aggressive measures. If it's a degenerative process involving the pulmonary circulation, I have to be aggressive. But in large number of cases, the bleeding might, like in tuberculosis, lots of time the bleeding, if it is non-massive, not or in TB, always it may not be massive, no, it may be non-massive. You may not have to go in for aggressive intervention in the patient. In some cases, the person might be requiring a bronchoscopy, balloon tamponade, and the bleed would subsequently stop. The main concept that I wanted to highlight was that bronchial artery embolization is the treatment of choice for life-threatening massive hemoptysis. Now, when would you say life-threatening? Then for life-threatening, the concept is more than 400 ml that I already said verbally. But he says that don't wait for 400 over the entire day. No? Like suppose he came right now and you estimated almost 100 to 150 ml in a single sitting. Even that is sufficient for you to deploy the protocol on the right hand side. And it's mainly the MCQs would come to you because massive hemoptysis has already been asked large number of times in the exam. Everybody knows the answer. Bronchial artery embolization is the treatment of choice. If not, then it is lung resection. If there's a tumor in the lung which is causing it, then I can go for lung resection also. So majority of questions that you will get nowadays will be a high risk patient of non-life-threatening, non-massive hemoptysis, and he will mainly ask you what is the investigation to be done in the patient, initial, and he will say that subsequently what is to be done. So we can be doing a bronchoscopy subsequently, and most of the time the bleed may, the word is may, settle on its own. If it persists, then again we go on to the right side of this flow chart. As far as vascular causes are concerned, you could be having mitral stenosis, heart failure as causes, and in mitral stenosis the source of bleeding will not be the bronchial artery. The bleeding would be occurring mainly with respect to the bronchial veins. In pulmonary embolism, it is the pulmonary artery and its branches that can bleed. Then good pasture is having anti-basement membrane antibodies. So these anti-basement membrane antibodies would cause damage to the lung vasculature and kidney vasculature, causing a combination of hemoptysis with hematuria. Then can be diffuse alveolar hemorrhage, which could be with cocaine or SLE. Then they love to ask regarding pulmonary renal syndromes, that is granulomatosis. I mean, the older term was, the GPA term is the new term, right? The older term that we were using was vaginous granulomatosis, but now we call it granulomatosis with polyangiitis. The details of GPA are given in the rheumat section. And then vaping also, I mean, in America, vaping part can also cause a development of hemoptysis in an individual. For malignancy, it would either be bronchogenic carcinoma, mainly it will be small cell and squamous. The most common lung cancer is adenocarcinoma. The most common lung cancer is adenocarcinoma, but small and squamous are the ones which can contribute to problems in the patient along with metastasis. And the last statement that I would like to state for this discussion, which will bring smiles to your face, is because I said last, it's been a fairly exhaustive exercise for you going through this entire rapid revision. The question said interstitial lung disease associated with smoking. The first thought process of one is, sir, smoking causes COPD. No, how does smoking cause interstitial lung disease? Yes, guys, smoking can be associated with interstitial lung disease also. The name is DIP, that is desquamative interstitial pneumonitis. Then is RBILD, that is respiratory bronchiolitis, interstitial lung disease. and then would be pulmonary Langerhans cell histiocytosis. PLCH is Langerhans cell histiocytosis. These are 3 interstitial lung diseases which can be associated with hemoptysis and has been asked in the ENISET exam. So especially this flowchart that I mentioned, the treatment of choice for massive, non-massive, the steps to be followed, and a couple of these important causes that I mentioned before you are the ones which are to be remembered. So these are the details, guys, which I would like you to remember for this discussion. And I would like to thank you for your patience and hearing me out this long for all these aspects that I've discussed. Additional point that I can say at this moment is, and I've said that in the routine courses also, that 2 videos of ABG, though I've covered the mixed disorders in this particular part for basic ABG kind of MCQs, where they ask you about routine compensated metabolic acidosis, partially compensated or fully compensated metabolic acidosis. How do you work that out? That is covered in 2 ABG videos which I would like you to go through. And then integrated medpath section, that's about 12 to 14 hours approximately. That would also help you improve your approach. But at this point of time, if you go through the RR component at least twice, you would be able to solve a chunk of MCQs. And yep, do ping me with respect to any queries that you have at my email, that is marvamedicine@gmail.com, and I shall be glad to assist you. I know you're doing great work and you will definitely come out with flying colors. It's just that be patient about the process that you are following. Every day it's a repetition. You eat, then sleep, work, and that work part has to be gradually increased. Work harder than what you did yesterday. As I say always, keep hammering, keep the pressure on, and you will definitely break on to the other side. Take care. God bless you.